all the way from Bangalore for this panel discussion. I welcome you, ma'am, to this panel discussion. Okay. And I also like to welcome Dr. Kailas, our State Secretary, a vibrant leader for this panel discussion. We'll move away with the discussion part. Let me come to our first panelist, Dr. Pramendra Gupta. Sir, I'll come up with the question, what is the most important role of family physician in promoting community health in our settings, especially in the Southeast Asia region, you being a regional head for Wonka?
Thank you, Dr. Nadeem, for this beautiful question. So, first of all, I like to aware you regarding the community health. So, community health plays an important role to ensure well-being of an individual in specific geographical location, and it encompasses health promotion, disease prevention, and primary care services. It also have a beautiful impact in, like they have a family physician as a first contact person, whoever, irrespective of age, sex, who needs health queries. To be remember that family physician used to be a first contact point in a community. Those countries who has already established a good primary care have set up a first contact point, family physician, only then the patient can be referred to other specialists. As we know our uniqueness, so our knowledge, our experience, and our uniqueness, and that is comprehensive care, continuity of care, integrated care, and person-centered care, which enables not only to look after the disease of a person, but also the mental, emotional, and social well-being of a person. We, family physician, provides continuity of care. We do follow a long-term relationship with the patient, and at the same time, we go through the disease perspective and look thoroughly what this person is having entire to their life. And this not only decreases the burden, because we do early detection of the chronic disease and do management. So this decreases the burden of chronic disease in a community. And it's our role to educate the patient to choose a better lifestyle, healthy lifestyles, preventive screening, and immunization. As we see in the morning, our presentation, which is based on how to manage dyslipidemia, which is the chronic disease management, and then the immunization. Because most of the people will come to you even to know what are the immunizations that we have to take and what are the essential immunizations that we need to take. So those knowledge we have to be, and we educate the person so that the community health will be taken care. And with education and with empowering the individual in a community with the personalized healthcare plan will save and empower the community with better health. Thank you.
Thank you, sir. Let me come to Dr. Sirin. What are the challenges do family physicians face in translating awareness into action? And can you just elaborate how they can overcome them while overcoming these challenges for translating this awareness to action?
So, thank you for that question, Dr. Nadeem. So, we all are proud that we belong to Kerala, and we have one of the best healthcare systems in the world. But as we practice, there are certain hurdles we face. One is the difficulty, one is the lack of awareness. So what actually I mean is people are aware of diseases, and they believe, they know that there are treatments, scientific treatments for them. But they don't know how to take it, how to approach, and where to get these treatments. Second thing, there are certain cultural practices, certain beliefs may not be religious, but localized to some regions. For example, some people, I'm quoting from my practice, some people believe that whenever you get an injury, you should get a tetanus toxoid vaccine. And what we do is, whenever we, especially in government setup, when we see patients, so it's better to prescribe those injections and patients are happy. That's one side. Second challenge is time. So this relates to the first thing. So there are misconceptions, lack of awareness, and when it is combined with time, lack of time, it adds up. So coming back to the previous example, so we know that it's not needed. So as per current recommendations, we don't need frequent vaccinations against tetanus, right? But to educate and to empower patients, it takes time. And especially in our setup, when we have to manage a patient load of 100 or 200, how are we going to address that? That's the concern. The third thing is lack of support. So as Dr. Nadeem already mentioned, who are we? Few years back, we lacked identity. Means whenever we start practicing, even now, some of our colleagues are very reluctant to put our degrees along with our names. Some people write just MD or DNB or whatever it is. They are reluctant to put family medicine as qualification. Why? Because there is no support from the public or from the other existing systems. So how to overcome this? Now, at least in Kerala, we have a good number of family physicians. So it's a collective approach. And if we try to educate, means maybe we assume that nothing will happen in 1 or 2 minutes. Especially those who are working in government sector find it difficult to dedicate more than 1 minute per patient. But even when we say that it's not needed, patient will think. That will spark the thought. So this is how we can overcome those kind of challenges. Even if we try, it may not be accepted in the first attempt. But after a few years, because you are going to be there and they will start believing in you. So in that case, over time, we can overcome those kind of hurdles. So that relates to the time issue as well. So you don't need to spend 10 or 20 minutes as the Western guidelines say. But if the patient feels that you are connected to that particular patient and you are telling the scientific fact for his betterment or for her betterment, then they will try to accept it. As I already mentioned, it will not happen in the first attempt, but it will definitely happen. And now about the supporting system. So this is a more challenging thing. So how we are going to overcome this thing? So what changes happened in the last decade? So we started, and our founder president is sitting here with, I can see the pride on his face. So we changed those beliefs in the last 1 decade. There are many people who contributed to the growth. So it's not a job entrusted with a particular person. It's our responsibility. We have to take it. Whenever we try, whenever we practice, whenever we say that we are family physicians, and whenever we say, means we are different. Let me quote one more example. People come with respiratory symptoms. Usually what happens, this happens with me now also. People ask for what? They come, doctor, I have cold, doctor, cold, cough and fever. I need azithromycin or amoxiclav. Earlier it was easier to get from medical stores. Now also they get. But at least now some pharmacies restrict it. So they come to get antibiotics. Straight away they say, doctor, I need antibiotic. So now you counsel them. And then they will think, who is this doctor? Why he is saying that? Why he is not giving medicines? So even with these kind of small steps, we can make changes. And over time, I can guarantee you, whoever has established practice will support me like anything. Because this is what we have seen and will continue to see. Then we will come across more things during this session.
Thank you, Sirin, for elaborating regarding the challenges and the various ways of tackling it. Let me move to Dr. Jyotika. Jyotika, can you explain how family physicians can better connect with their communities? Have you any experience at the Bengaluru from your state? You can share, please.
Yes, thank you, Dr. Nadeem. So I think as our name itself suggests, are the specialty, family physicians. So we have to make it important that we connect with the entire family, with the patient. But the biggest question, how do we do it? I think the first thing that we should do, and I think all of us should get into our practice, whether we are in a government setup or a private or an institute, firstly introduce yourself and call the patient by his or her name. It really is a very easy thing to do, and the patient is going to remember. I think you may have noticed when people come to us from another specialist or even from any other doctor, if you ask them, Acha, whom had you gone to and what had they prescribed, they may not remember their name. So we can make that start, how to connect, introduce yourself and also remember the name of that patient. And then, as Dr. Serin also mentioned, if there is a lack of time, use statistics or use guidelines, mention it so that they understand that you are talking with evidence or you have some support in the care that you're giving. And you are not trying to finish the consultation because of lack of time. And once they realize that your care has actually cured them of the disease, or even if it's a small ailment for them, or if you have given a very reasonable explanation. Of course, this is a daily habit. People come to us saying, we are traveling tomorrow and please give me antibiotics, or I have an exam, can you give me something for my stomach pain? Very, very common complaint that they come with. But if we justify to them and convince them in the right way, may not happen with everyone, may not happen in the first time, but definitely they will come back to us with much more confidence. So I just want to quote one example that I had in my practice recently in Bangalore. So there was a patient sitting in my OPD asking for antibiotics itself. And I had to clearly refuse. I did give my explanations and I did not prescribe the antibiotic. So there was a family sitting outside. So the lady walked in after this consultation got over. And she said, doctor, this is the first time I have heard somebody saying, a doctor has actually refused giving antibiotics because I have had a very bad experience with some allergy that I had bought from outside. But nobody had really guided me at that time. So somewhere we have to make the first step.
Thank you, Jyotika. Kailas, already Sirin has explained about the challenges what the family physician face, and he has also put something to overcome that. Let me discuss. Can you just elaborate on the unique health challenges that family physician face in Kerala, especially in government health sector? And is there any wise words from you to put forward to address that things?
Thank you, Nadeem. The question
what are the challenges that we face in Kerala? Being a doctor in Kerala Government Health Services, we are daily facing such problems. You all know that. Most of us are practicing in Kerala itself. So we all know what are the challenges that we face. Actually, the population, the aging population, we are always dealing with an aging population. Now, we all know that there's an overburden of NCDs, there is mental health problems, overcrowding of the public health facilities, and inadequacies of primary care in the private sector. And so many challenges are there. As we all know that, and we are all going through that every day. So, how a family physician can be an answer to these challenges, or how can we tackle that? We are now only a small group, around 400 or 500 people overall in Kerala. But with these 400 or 500 people, we may not be able to overcome this whole scenario, but we may be the answer for the future. Like family physicians being the point of first contact, we may be able to change the social stigmas, like as we discussed here. We may be able to talk and communicate with the people to reduce these social stigmas, and even all the environmental and healthcare challenges, like lifestyle modifications, etc., can be easily be instilled into the public by the intervention of a primary care physician or a family physician. So in our practice, we should make sure that we are doing the family medicine way of practice, even we are practicing in primary care, secondary care, or tertiary care, or even in public or private health sectors. We should instill the way, and this is the consultation styles as we talked about. We should talk to them. We should be the change. And also addressing this, apart from this, we are dealing with a comprehensive continuous care. And we are not at all on the curative side only. We are also engaged, and we should engage the patient in the preventive care, promotion of health care, palliative care, rehabilitative care. We should be a part of everything, and we should be a part of the family, and we should be a part of the society also. So the first thing we have to do is to ensure to tackle these challenges, we ourselves should get into action first. We should be aware, and we should be able to be action takers in the society. That can change the that can tackle the healthcare challenges that we face in Kerala to an extent. Over a period of time, we may be the answer. We may be the only answer. Thank you.
Thank you. We are already running short of time. I request the panelists to make it very crisp. The answers can be tailored within 1 or 2 minutes. So moving to Dr. Pramenda, you being a leader for the Wonka, let me ask, how can family physicians make global health strategies work at this local level?
So first, we have to adapt those global health strategy and try to fit it on a local perspective and see how it goes to fit with your cultural, economic, and social aspect. Second, we have to address what are the healthcare needs and priorities in the communities. We have to uplift the health literacy of the individual within the community, and then at the same time we have to advocate for the policy change which can adapt those global health initiative for local health goals. I'll give you certain examples. Like if you go to an example with better primary care, which has adapted nowadays. Even in Nepal, Nepal is the worst country which is having worst maternal mortality rate. But since we advocate and we educate the other healthcare workers in promoting the healthcare to maternal and child health, we uplifting our maternal mortality rate. Even in the sub-Saharan district also, they adapted those healthcare policy and train the healthcare workers who provide healthcare services locally to the maternal and child care services there. Even in Brazil, the Family Health Division adapted these global health strategies and make it fit to underserved area. And you can see a better example of Brazil who have achieved a good primary care recently. Even in Bangladesh, we talk about the technologies. There is a M Health. With the support of M Health, they have developed maternal child health practices through M Health, and they have uplifted the maternal child services throughout the country. So these are the better examples which we can go through. So we can adapt those things to our local needs and local perspectives.
Thank you. Sarin, what role can AFPI play in promoting preventive health measures within communities? You being an AFPI person for years, I think you are the right person to say the same.
AFPI works at different levels in promoting as well as preventing health conditions. So, and whenever I say AFPI, it doesn't mean that if few people who are office bearers or national executive members. No. Whenever I say AFPI, it is about us. And how are we going to make that? So to address this, we have to educate. So as we always say, so education is the answer to many of the problems. So how are we going to do that? Or how do we practice right now these? How are we addressing these issues right now? So as I already mentioned, we educate, we teach people, we teach our peers, we try to throw light to the authorities. So COVID was an example. Everyone was unaware of COVID before 2020. It was limited to a few sentences in most of the medical books. The coronavirus itself. Then I remember we conducted a lot of training programs for our members as well as for other doctors. And we became a part of that teaching group. We, again, I say not just the AFPI executives, we all try to teach the public. This is just an example. And even when we attend these kind of things, we are learning new things. We are coming across new practices, new guidelines, all those things. And whenever we go back to our areas of practice, we conduct classes, we conduct sessions, and we try to make that change in the society. And AFPI plays a role in nurturing these leaders. And these leaders will take this care, this continuity of care to next level. This we have seen in the past. And 10 years back, as I already mentioned, there were only a handful of people. Now we are associating with so many programs. We are associating with TB programs at state level. We are associating with Ardhram Mission. There are so many programs where we are engaged. And we, in all places, we are being recognized as family physicians. And we have a say at all places. I can elaborate, I can go on for hours explaining this, but...
Okay. Dr. Jyotika, being from the tech city, I think you are the right person to say something about the technology, the role of technology in family medicine. I know you are using all sort of technology in your practice. Can you just elaborate a little to this audience regarding this thing?
Yes, I can elaborate to the audience, but can the audience quickly give me 2-3 examples of how technology is being used by all of you in the practice? Anything? Okay. Yeah. Mobile apps for? So it's like an electronic medical record, can I say? Anything else that is being used? Continuous glucose monitoring. I think, Dr. Oliver, you're also from Bangalore. Yeah. So, continuous glucose monitoring, the BP monitors, that is the ambulatory BP monitors, and of course, electronic medical records. All these are being used by all of us every day. And COVID has shown us the importance of teleconsultation, wherein if the doctor cannot reach the patient or vice versa, a doctor is always available for any patient anywhere in this country and actually sometimes even outside of the country. And I'm sure we have a lot of such patients who do contact us when they are either in the UK or US or even Australia. So these are the few examples of the digital help that we can take. But apart from that, one thing that I want to add is, as much as possible, please be present on social media because it does help in creating awareness in the right way. Like Dr. Bijay said, he does tell his patients to switch off the phone. The reason is because there is a lot of misinformation outside. So the way to tackle this is, if a patient says they have so-called Googled it and come, they have read this somewhere, give them the right website or the right link. We can, I have done this in my clinic also. We have put QR codes, we have displayed it, say for diabetes education, for vaccination. So when they scan the right thing and they read it, then it helps you in the long run, rather than spending time solving their doubts and clearing their misinformation. So I think we should be smart enough to use technology in the right way.
Thank you. Dr. Kailas, AFPI Kerala torchbearer, being an AFPI Kerala torchbearer, can you just explain how AFPI Kerala help family physicians improve their role in primary care?
As we are coming, the AFPICON Kerala is coming for the first time in Thalassery. I just wanted to explain that. AFPI Kerala is a organization formed by a group of family medicine doctors. It all started in 2014 when when there is a less than number of 10 or 20 family physicians were there. Under the leadership of Dr. Vijay Raj, we formed a AFPI Kerala Chapter. At that time, I was doing my PG, and when I took family medicine, the usual question which you all have encountered was asked by my colleagues also: what is family medicine? What is this? Where are you going to practice? Such questions were there. At that time, AFP was our identity. When every other group of doctors were going for their own conferences and all, we were actually at a dilemma that where should we go? Then in 2015 January itself, we conducted our first state conference in MIMS. Then at that time, I still remember the number of delegates were less compared to now. But over a period of this is the 9th annual state conference being held in Thalassery. Now the numbers are exponentially increased. Even the number of members in AFPI Kerala is around 300 to 400. The total number of people. And apart from this is the growth of AFPI along its way. And now what we are doing for the fellow family physicians in that is improving their academics for the constant academic programs are being held in various parts of Kerala through different zones. AFPI Kerala is also divided into different zones: mid zone, north zone, and south zone. Each zones are separately conducting their own academic programs for the young family physicians and also for the students to improve their academics, etc. And also we would like to, we are also planning to streamline the job opportunities for all family physicians and to streamline we are going to start a discussion on streamlining the payment structure for family physicians also. in the very recent. This way, AFPI is bringing about changes in the academics and practicing aspects of everything. Even we have workshops on how to set up family practice clinics. So many structures, so many things are happening in various parts of Kerala, not only in this state conference. Various conferences or small gatherings are happening all around Kerala over this period of time. In this way, AFP has become an identity and also helping us grow together. Apart from that, being the AFPI Kerala is also training its next generation leaders to take us to the next generation. Even this, I already told you that we are divided into different zones and we all have office bearers for that. And we all change these office bearers every 2 years so that the next generation will come up and the newer and newer people will have the opportunity to take us to the next level and to show their passion for family medicine itself. So we all should stick together and be a part of this AFPI family. Not this AFPI Kerala chapter is not just a national executive, but a collection of doctors together where there is no hierarchy exists. Thank you.
Thank you, Kailas. To the final round. Don't see the timer. It's already late. We have 9 more minutes. Let me come to a concluding statement from each panelist. Let me request Dr. Pramendra, your concluding statement to this audience. What advice you would give to the family physicians to turn awareness to action very effectively?
Thank you, but I'll take some time in this question. First of all, you have to be a good communication skill. As in the morning, Dr. Vijay has already showed you what communication skill is and how important is that. And you have to make a good rapport with the patient. Now, talking about Dr. Vijay, he is a very good friend of mine. Whenever I got a time to talk with him, I learn a lot. And last time, I was there in a conference in Kerala. Actually, I am very fascinated with the Kerala conference. I am a regular member of a Kerala conference. Last 4 years, I was not able to attend any Kerala conference over here because Dr. Indu is here. I organized a workshop with her where I teach about the basic emergency skill. And the last presentation which I saw with Dr. Vijay is one of my best and favorite presentation where he correlated Bollywood movies with the health issues of a state. And it was beautifully presented. So it's a beautiful and it's a beauty when you attend the conferences. So try to make a good rapport with your colleagues, try to make a good rapport with your patient, have a good communication skill, go thoroughly and do a good patient interaction so you can get known with the disease condition of the patient. Like one of the speakers already told you regarding the hidden type of diseases. So we have to find out those hidden type of diseases also. So this you can incorporate in your lifestyle and do a better practice. Now, I would like to talk regarding Vonka also. So I have given you certain example, I have given you certain few things for a primary care also. So if you go to a Vonka website, you will have a lot of materials on primary care and lot of essentials things you will have in the website. There are different working parties in the Vonka. And if you people are interested, you can go to a Vonka website and try to join that working party. There is a WhatsApp group. You will know lots of things what's going throughout the world and what is going throughout your own state also. Because attending a conference that you come from a certain place with a group of people and you do interact with your group only. Try to interact with the other state people. Try to interact with the other country people so you can get to know what are the different perspective of a health in that country. Last time when I visited Kerala, I was very lucky to go with Dr. Vijay to a village and where I known with the local cultural perspective of that village. And that had given me better idea where I can relate with my cultural perspective also. So try to attend more conferences, try to give good relation with your colleague and other friends. There is a conference coming in Bangalore, so I invite all of you, try to attend that conference. That's a regional conference and you will meet lots of other people who will from the other countries and other states. Thank you.
Thank you, Pramendra Prasad, for elaborating nicely. And I also thank you for attending all the Kerala conference. And great knowledge for me was that he is a Nepali who has visited all the 14 districts in Kerala. I don't think most of you might have done that, sir. And I can call him Malayali by next conference. Thank you,
I
sir.
think I should learn Malayalam now.
Yeah. Okay, thank you. And let me request Serin to give a final comment. How AFPA and family physicians can bridge the gap between health awareness and actionable change in patients' life. Can you elaborate it within a minute or so? Because we want to wind it up soon.
So, as an organization, AFPI always try to bring people under one umbrella, and these kind of events like AFPICON or FMPC, all these are events to bring those people, means bring our colleagues under one umbrella, where we can feel that we are a part of this big family, where we learn new things, new guidelines. As a primary contact for the society, we can make cultural changes which no other specialty can make. But the problem is, we don't have belief in ourselves. We don't value ourselves. Dr. Kailas was mentioning about going to conferences. So this was the trend few years back. Now also at least few people think we should attend internal medicine conference, cardiology conference, diabetes conference, rheumatology conference. There are many more conferences we should attend. But why to attend family medicine conference? This is the place you come across with new developments in family medicine. So we think that we should attend and learn so that we can guide or we can read. So during our PGs, we learned so many things and we continue to learn. And my teachers are here. From my PG days, they are here. What I was taught, PG postgraduate training is the time when you realize that this is how you start to learn things. That's not the end, that's just the beginning. So it's a lifelong process. So what's the importance of this with the public health? If we are not aware of these latest advancements in healthcare, in primary care, how are we going to make the change? Today we had a quiz for postgraduate students. Not surprisingly, most of the students were not even familiar with the latest technological advancement in primary care. I'm not telling about diabetology. People are running after all these subspecialties. But we are not aware of our own, where we can actually make changes. Dr. Kailas already mentioned how we can make changes in the coming years. So as AFPI and an organization, we are trying to empower our own members. And we try to intervene at all possible levels so that we can conduct training programs, CMEs, conferences, workshops, and gradually over period of few years, we will achieve that goal. We will empower ourselves, we will empower the society, and we will make the change.
Thank you, Dr. Serin. Dr. Jyotika, your concluding statements regarding simple steps that can be followed by family physicians to promote healthy habits in their patients. Can you just make it short?
I will. So the first thing that we all must do is have that practice in ourselves. If we do not exercise, if we are not healthy, if we are not alert or cheerful, if we are irritable in our practice, our patient is never going to connect with us and our patient is never going to come back to us, I think. If we are sitting and advising about lifestyle disease prevention, because the NCD is prevalent, But if we are obese or, shabby looking, not kept ourselves up to date, I think we really cannot convince our patients at all. So the first step is we should practice what we want to preach. I'll keep it short.
Thank you very much. And our panelist Kailas, your closing remarks, that your vision for family medicine in our state in coming years. Can you just make it short?
Okay, my vision for family medicine in the coming years should be divided into two parts. One is in the public sector. In public sector, as you all know that we are in constant meetings with the government regarding the family medicine and all. But as you all know that these policy changes needed a lot of time. But as a part of this Kerala government, we all know that there are subtle changes are being happening in Kerala government. People are recognizing the role of family medicine people, and it's on the way, but it will take time. But my greater this is for the private sector. In private sector, the primary care is still needs to be more explored. And my vision for this, or I urge everyone in this audience to have a personal, to be an entrepreneur by themselves. Start their own clinic or start their own short practice at your home or a clinical setup nearby your home, just for 1 or 2 hours, apart from your routine job at some other hospitals or thing. This routine practice or your own patients are going to be the game changer for your life also. Because primary care is the place which is most unexplored in our health setup, and we are the right persons to explore that before some other people will come and explore and take that away from you. Thank you.
Thank you, Kainas. Thank you, panelists. Before closing, I know there are a lot to speak from these experts, but we have short of time, and me being the timekeeper, I ask, we will finish it up at 11:30. As our great teacher, PK sir, we all know PK Shajiran sir used to say, like family medicine specialist is a friend, philosopher, and a guide. I think that 3 words put this theme into action. That's from awareness to action. And once a patient comes to our OPD, we must understand whether we want to balance this theme, like whether the awareness part is more required for this patient. Sometimes patient will go to big tertiary hospitals, and it's not sometimes, it is the most common thing happen in our OPDs. Patients will come with 2 big files from the tertiary hospitals. They have consulted all the super specialists and subspecialists, and they want to meet us to know whether a glioma need to be operated or whether a CABG want to be done. Everything regarding the same might have been explained by the specialists or subspecialists there. But they want to get a companion in making this decision. So we want to take this theme forward in our practice, that what PKS used to say, that let us all be friends, let us all be philosophers, and sometimes let us all be guide to our patients. With these concluding remarks, let me stop this panel discussion. I thank each one of you for joining us. And being a scientific chair, I'll put 2 announcements, that 2 parallel halls are running, poster presentation on my right side and workshops on my left side. And in Hall D, in ground chairs, there is oral presentations going on. And please make sure your time, the presenters, make sure you have time and be there in the hall on time. We want to finish up all our sessions by evening 4. And let me also announce that tomorrow our speaker for inaugurating the event will be coming by 9:30 sharp. So all be here by the time the event starts at 9 itself. Okay, and also for your notice, let me say that we are having a beach tour today evening, and we'll be taking you all to Murpangan Driving Beach, which is the second largest beach, driving beach in Asia. And I request each one of you to give your names in the registration counter. With these words, let me conclude this panel discussion. Thank you, one and all.
This marks the end of the panel discussion. I invite Dr. Vijay sir, founder, president AFPI, to hand over the mementos to the panelists. Dr. Pramendra Prasad Gupta. Dr. Serin Kuriakose. Dr. Kalas P. Dr. Jyotka Gupta. Also to our moderator, Dr. Nadeem Abouti. Thank you, sir.
Let me request Dr. Jyotika to address this gathering, to invite you all for Wonkasar happening at Bengaluru.
Thank you, Nadeem. As Dr. Pramendra Prasad just mentioned, the next conference is in Bangalore in April 4th to 6th. This is the Wonka South Asia Region Conference, and I want to invite all of you to be a part of this. And, we will be able to meet a lot of people from across the world. So, another offer that we are announcing at this, anyone who has registered for AFPICON Kerala is eligible for a 10% discount for the Wonkasar conference. But please give in your name and other details to Dr. Vishnu by tomorrow midnight, so that then the process of creating the discount code and registration can be done. Thank you.
We have a series of interesting sessions coming up. We have the bullet sessions on incidentally detected asymptomatic conditions. I welcome Dr. Rashmi S. Kaimal and Dr. Vishnu to chair the session. Dr. Rashmi S. Kaimal is the head of the Department of Family Medicine at Lutz Hospital, Postgraduate Institute of Medical Science and Research, Kochi. She is a National General Secretary of the AFPI. She has many publications in index journals, and she is a faculty in various national and state conferences. Dr. Vishnu is a specialist and academic coordinator, Department of Family Medicine at KIMS Health, Trivandrum. Over to you.
Good morning, all. So now we are moving on to bullet sessions. That is short sessions on incidentally detected symptomatic conditions. We have 6 sessions coming on. So the first session would be on asymptomatic gallstones. I invite Dr. Fahmy for delivering this session. Dr. Fahmy is a consultant family physician at Muthoot Healthcare, Kollajeri. Over to you, Fahmy, for this session.
Good morning, one and all. Thank you, the organizing team, for giving me this opportunity. because of short of time, I am directly going to the topic. Mrs. Priya, a 45-year-old woman, had a routine health checkup as a part of her company's annual wellness program. An ultrasound study of abdomen revealed a 1.5 centimeter gallstone. She had no abdominal pain, no nausea, and no signs of jaundice. Should she be concerned, or should she take action, or simply wait and monitor? So, what is an asymptomatic gallstone? Gallstones are solid stones formed in the gallbladder when there is an imbalance in the composition of bile. An asymptomatic gallstone is a gallstone that is present in the gallbladder but does not cause any symptoms. These are discovered incidentally during imaging studies for other unrelated conditions. So, the prevalence of gallstone, the worldwide prevalence is 6%, and it is affected more in America and other Western countries, with less prevalence in Africa and Asia. Cholesterol stones are the most prevalent subtype. Prevalence increases with age and in female. Most cases are asymptomatic. Only 20% of asymptomatic gallstone develop clinically significant complications. So I am skipping this slide because of lack of time. And as we all know, there are multiple factors are associated with the development of gallstone. We can memorize the risk factors of gallstone as 5F. First one is fatty. Fatty means obesity. Obesity increases associated with there is an increased prevalence of gallstone in obese patient. As obesity is associated with there is an increased insulin resistance, it causes the increased secretion of hepatic secretion of cholesterol, and also there is an hypomotility of the gallbladder. Next is 40. 40 means age. As age advances, there is an increased incidence of gallstone. Next is female. Females are more prone for developing gallstone compared to male. This is because it is attributable to the female sex hormone, estrogen and progesterone, and also to the pregnancy and also oral contraceptive pills. Next is fertile and fair. Other risk factors associated with the gallstones are comorbidities like diabetes, hyperlipidemia, sudden weight loss, especially after bariatric surgery, and drugs like oral contraceptive pills. Do asymptomatic gallstones require any treatment? Most cases of asymptomatic gallstone do not require any treatment. But in some subtypes, they require prophylactic or preventive cholecystectomy. Expectant management is the best approach. What are the risks of leaving asymptomatic gallstone untreated? So we can see the pros and cons of observation alone, that is the expectant management. Considering the natural history of the asymptomatic gallstone, it is usually benign. Only 1 to 4% of patients per year symptomatic. Only 10 and 20% of patients will develop symptoms at 5 and 20 years. That is their lifetime. And acute biliary symptoms occur in 3%. Most of the patients develop symptoms before developing complications like biliary colic. And patients, we can avoid the surgery and anesthesia-related morbidity and mortality, and we can avoid the unnecessary cost or workload for the health system. Patient can be operated and when he or she becomes symptomatic, and avoidance of unnecessary surgery or anesthesia in patient with multiple comorbidities and in advanced ages. So coming to the disadvantages, there is a theoretical potential of development of gallbladder cancer and acute pancreatitis in patient with the gallstone disease, and 20% of patient will develop symptoms after 20 years. Compared to elective surgery, as we all know, emergency surgery is always risky, and expectant management is contraindicated for selected subgroups of patients. So next question is, do I need regular checkups or imaging tests to monitor the gallstone? Yes, the monitoring is mainly for to ensure these gallstones do not progress to symptomatic or complicated gallstone. So the monitoring includes physical examination, risk assessment, imaging, and blood investigation if needed. The routine monitoring interval is 6 to 12 months with patient with the risk factors and newly diagnosed gallstone, as the risk complications are more in the initial years of diagnosis, and 1 to 2 years patient with the stable gallstones and no risk factors. The most common imaging method used are ultrasound abdomen. It is usually performed at the time of initial diagnosis and it is repeat after 1 to 2 years if stones are small, asymptomatic and no other risk factors. If any new symptoms occur in between, should undergo imaging immediately. All patients who is on expected management should be educated on the warning signs of gallstone related complication, such as the severe abdominal pain in the upper abdomen, yellowing of skin or eye, nausea and vomiting, heavy sweating, itchy skin, fever and chills. So the most common clinical presentation of is biliary colic, and also I am skipping the slides. The most common complications like acute cholecystitis, choledocholithiasis leading to ascending cholangitis, acute pancreatitis, gallstone, ileus and gallbladder cancer are very rare. So we have to know under what circumstances would surgery be recommended. Most large gallstone, like gallstone of size more than 2 centimeters, require an elective cholecystectomy. It is the evidence in a case control study of 81 gallbladder cancer cases, the risk of malignancy was more than doubled with an odd ratio of 2.4 for patient with a gallstone diameter of 2 to 2.9 centimeter. The neoplastic risk was more than 10-fold in those with gallstone diameter of more than or equal to 3 centimeter. So for all gallstone size of more than or equal to 2 centimeters should undergo an prophylactic cholecystectomy. And gallstone is associated with the gallbladder polyp of more than 1 centimeter in diameter. So the exception to expectant management in person with asymptomatic gallstone are, first one is calcification of gallbladder, that is porcelain gallbladder. Why this is this is an exception? This is due to high risk of gallbladder cancer. Hemolytic anemia, there is a high risk of development of pigmented stones and due to chronic hemolysis. Large gallstone, there is high risk of gallbladder cancer. Morbidly obese undergoing bariatric surgery, there is high risk of becoming symptomatic during rapid weight loss. And Native Americans are more prone for developing gallbladder cancer. And patient is planning to have a transplant. There is chronic immunosuppression. This is also an high risk. And small gallstone and gallbladder dysmotility leads to high risk of pancreatitis. So, are there any non-surgical treatment for asymptomatic gallstone? Actually, the answer is no. This non-surgical treatment like oral bile salt therapy and the extracorporeal shockwave lithotripsy is only for symptomatic patient who is not undergone surgery or not fit for surgery. As we all know, the ursodeoxycholic acid, this is a gallstone dissolution agent. It reduces cholesterol saturation. The common lifestyle tips to reduce the stones are exercise regularly, eat a healthy diet, maintain a healthy weight, lose weight gradually and not rapidly, do not skip meals, try to have meals at a fixed rate. So, what's the role of family physician? Family physician plays a critical role in the management of asymptomatic gallstone by patient-centered care, education and appropriate referral, diagnosis and assessment by history and examination, patient education on the nature of the condition, symptom awareness and risk factors, risk stratification by identifying patient at high risk, and lifestyle counseling, refer to higher center for elective cholecystectomy in selected cases, and on psychosocial support by addressing the anxiety of incident findings. Special considerations are geography variation. In northern India, it's more there is more prevalence of gallbladder cancer. So even if the patient is asymptomatic gallstone, there should be a region-specific guidelines. And diabetes and cirrhosis, it is contrary to earlier beliefs. Diabetes with asymptomatic gallstone do not require routine prophylactic cholecystectomy. Cirrhosis surgery is avoided unless symptoms due to high surgical risk. And gallbladder cancer is also associated with the large stone and chronic cholecystitis. The conclusion, incidental gallstones are detected incidentally during imaging studies performed for unrelated condition. The decision to treat symptomatic gallstone should be individualized, weighing the low likelihood of progression against the surgical risk. Selective cholecystectomy is advised for certain subgroups. And, further studies required, particularly in high-risk areas like northern India, are needed to refine the guidelines. Thank you.
Thank you, Dr. Fahmi. So we are moving on to the next session in this bullet session category. It's the topic on lymphadenopathy. To speak on this topic, we have Dr. Joyce Joseph. He is a consultant family physician and head in Department of Family Medicine at ICRA International Hospital, Calicut. Over to Dr. Joyce.
Good morning, everyone. Topic is lymphadenopathy. It's a bullet session, so everything has to be concluded in 10 minutes. Lymphadenopathy usually presents as we find it an incidental finding. Sometimes the patient may present as a swelling in the neck or inguinal region. Definition is nodes that are abnormal in either size, consistency, or number. Maybe in normal reactive places, or sometimes it may be due to a pathology. Classification is mainly based on is it localized or generalized. Commonest is localized, almost 75% is localized. The other one is generalized. Localized is there is only one area is involved, and 50% of this involves the head and neck region. Generalized lymphadenopathy, where there are 2 or more non-contiguous areas are involved, it's typically indicative of a systemic disease. Evaluation and management, as usual, a proper history, physical examination, then we reach a differential diagnosis, and we decide if there is any specific test needed. Then we treat the disease and then only reassess. In history, we have to take care of some important points. That is, if it is associated with any other arthralgia, rashes, or muscle weakness, and past history of any other diseases like HIV, lymphadenopathy, lymphoma. Also, more importance to be given to the social history, their chemical exposure, alcohol, tobacco, sexual history, and history of malignancy in the family. Also, any other localizing symptoms to suggest an infection or neoplasm in a specific site. Are there any constitutional symptoms? Epidemiologic clues like occupation, travel, high-risk behavior of the patient. Medications. Some medications cause lymphadenopathy. These are the drugs that causes lymphadenopathy. And commonest among these are what we use commonly are cephalosporins and atenolol can cause. Then in physical examination, as always, vitals. Then head to toe examination should be taken care of, especially in in lymph nodes involved in the head and neck region. And a proper scalp infection can cause, and dental problems can cause a lymphadenopathy, which is most commonest thing. So first we have to examine there. Then if there is any lymphadenopathy identified, we have to palpate for the spleen and liver. Also basic other auscultation, and mainly concentration should be given on any skin rashes or lesions on skin, and any nodules are there. In physical examination, and we have to, if it is localized lymphadenopathy, we have to examine the regions drained by that particular node, and you should look for any ulcers or infection, skin lesions or swelling. In cases of in localized lymphadenopathy, we have to look for other nodal sites also to exclude the possibility of a generalized lymphadenopathy. Then in clinical examination, we have to describe a lymph node in terms of site, size, number, consistency, overlying skin, mobility, tenderness, and matting. In terms of size, usually more than 1 centimeter, a node more than 1 centimeter is considered significant, with the exception of epitrochlear lymph nodes, which is significant if it's above 0.5 centimeter, and inguinal lymph node above 1.5 centimeters. Usually surface area is more specific. Less than 1 into 1 centimeter square of surface area in a lymph node is usually benign, and more than 1.5 into 1.5 may require more investigation, so you have to be more careful. In children, all nodes more than 2 centimeters should be considered significant and properly evaluated. Pain and tenderness of the node should be taken care of. As the node enlarges, it touches the capsule and causes pain. Usually, it's a sign of an inflammation or suppuration. It's rarely some hemorrhage into the necrotic center of a malignant node can happen, which is and so pain and tenderness is very non-specific. Consistency. Some diagnostic clues we may get, that is very hard nodes, usually from metastatic cancer, very firm and rubbery in lymphoma. Softer nodules are seen in infection and inflammation, and fluctuant nodes are seen in suppuration.
Small nodes like buckshot under the skin, usually seen in children, it's called shorty. It's usually benign in viral illnesses. Matting, that is a group of nodes that feels connected and seems to move as a unit. It can be benign or malignant. Benign conditions, mainly TB, sarcoidosis or lymphogranuloma venereum. Malignant conditions like metastatic carcinoma or lymphomas can also present. These are the sites that we should examine. Cervical, axillary, epitrochlear, pelvic. Cervical lymph nodes are classified into deep and superficial. Superficial and in supraclavicular lymph nodes, in cervical lymph nodes, these are the deep cervical lymph nodes. Supraclavicular lymph nodes are most important because they have a highest risk of malignancy associated. And 90% in people more than 40 years of age, 90% of palpable supraclavicular lymph nodes may be malignant, and in less than 40 years it decreases to 25%. And this left supraclavicular lymph node, it's called Firko's node. Palpation of that node is called Rosier's sign. It's usually a sign of malignancy in the thorax and abdomen. And right supraclavicular node drains from the mediastinum, lungs and esophagus. So that also should be palpated. Sister Joseph nodes is very rare, paraumbilical node. It's in abdominal or pelvic neoplasm. Also, these are the 5 groups of axillary lymph nodes which we have to examine. Epitrochlear lymph node is also a very rare lymph node. We can find the medial aspect of elbow, seen in some secondary syphilis, non-Hodgkin's lymphoma, HIV, disseminated TB, etc. Inguinal lymph nodes are divided into horizontal group along the inguinal ligament and the vertical group from the midpoint downwards from the inguinal ligament. Horizontal group drains from the external genitalia, scrotum, perineum, anal canal, and below the anal canal below dendrite line. And vertical group drains from the lower limb. So we have to look for any infections or ulcers or any other suspicious lesions in that area. Management, basically, we have management of lymphadenopathy is based on what conditions we are suspecting. So basic investigations like CBC, ESR, and CRP can be done. Chest X-ray should be taken to rule out. And specific test only according to the differential diagnosis, what we are suspecting. And imaging can be done to know the nature of the lymph node, the exact size of the lymph node, if it is matted, if it is all the clinical findings we can confirm using imaging. Then we treat the cause and then reassess. So in case of unexplained lymphadenopathy, where we cannot find any other cause for lymphadenopathy, that should raise a suspicious question and we should evaluate more. In generalized, it usually is due to a systemic cause, so we have to do specific investigations based on our clinical judgment, and then if there is no cause found, we have to do a biopsy. In localized, we can if we are doubt is a benign condition, we can wait and reassess in 3 to 4 weeks, and if it is not subsiding, we can go for biopsy. So these are the usual causes of peripheral lymphadenopathy. And in imaging, as I said, in children below 14 years, US is the preferred imaging. Above 14 years, CT is advised, but we rarely do it in the first instance. So the imaging helps to define the node size and distribution properly. And then the final investigation is biopsy. Excision biopsy is always preferred. And in conditions when we are suspecting lymphoma, that is the diagnostic one. FNAC is less invasive and it's more useful in case of occurrence of cancers. And corneal biopsy is less preferred compared to excision biopsy. Again, the treatment is depending upon the etiology. Infections, we treat appropriately, antibiotic therapy, antiviral, antifungal if needed. Autoimmune, we have to deal like that. Malignancy, surgery, we have to refer to the patient to the concerned departments. Medications, if it is due to any other medications, we have to discontinue that and then re-evaluate. The role of family physician is serving as the first point of contact for patients and guiding them appropriately. My main important thing is the proper history taking and physical examination and determining the probable cause of the lymphadenopathy. Risk factor assessment should be done properly. Any malignancy should be ruled out, and we have to provide reassurance and proper treatment for benign cases. And we have to advise the patient when to seek for further medical attention. Thank you.
Thank you, Dr. Joyce. So the next bullet session will be about deranged liver function tests, and Dr. Mamta Manohar will deliver this talk. She is a specialist family physician in the Kerala Government Health Services. Over to you, Mamta.
Good morning, all. Today's topic of presentation is liver function test. So liver function tests, they are a group of blood tests that are used to assess the status of the liver. But it comes with a disclaimer, because abnormal LFTs does not mean the diseases in the liver. It can arise from diseases other than the liver. And normal LFTs does not mean the liver is healthy. So individually, if you take the liver function test, they lack sensitivity and specificity. So always you have to assess as a battery of tests together. So the common liver function test you all know, but in this, only albumin, bilirubin, and prothrombin time directly reflect the liver function. Hence the term liver function test should be modified as liver biochemistries. So generally when you get a liver function test report, you can classify it as hepatocellular, cholestatic, infiltrative, or just isolated hyperbilirubinemia. Now, coming to the markers of hepatocellular injury, you all know aminotransferases, AST and ALT. So AST is found in liver, heart, muscles, and kidney, and brain. Whereas SGPT or ALT is primarily found in the liver, and thus ALT is more specific for liver injury. Now, normal values, you all know, it varies from lab to lab. You can see the normal ranges are different in different labs. And why is this? Because it does not follow a normal bell-shaped curve. There is always a skewed distribution with the tail towards the right. And this is because the population, it depends upon the population, whether the age, sex, BMI. It also depends upon the diabetic status and triglyceride levels of the population. Now, coming to the causes of elevated aminotransferase level, we can classify them as SGPT more than SGOT. The common conditions are viral hepatitis, drug-induced, NAFLD is better now termed as MASLD, acute liver injury arising out of drugs like paracetamol toxicity, and cholestatic hepatitis. Now, coming to SGOT more than SGPT, as I said, it is not restricted to the liver. It can be alcohol liver disease, autoimmune condition, metabolic liver disease. Cirrhosis, why? Because there will be decreased hepatic blood flow, and then the SGOT clearance will be less. Rhabdomyolysis, hypothyroidism, and myocardial infarction. Now, in our practice, we generally see as mild to moderate elevations, that is less than 5 times the upper limit of normal. And the common conditions are MASLD, autoimmune hepatitis, chronic viral hepatitis, hemochromatosis, medications or toxins. Wilson's can cause both mild elevation and severe elevation, and rarely only alpha-1 antitrypsin deficiency. Now, severe acute elevations, this is the one which we should be alarmed of. Hepatic causes like acute bile duct obstruction, acute Budd-Chiari syndrome, acute viral hepatitis, autoimmune hepatitis, drugs or toxin, ischemic hepatitis, and Wilson's disease. Now, coming to SGOT elevation, the mild elevation, you all know alcohol-associated liver injury, cirrhosis, and non-hepatic causes you have to think is hypothyroidism, myopathy, and strenuous exercise. When you get a severe acute elevation that is more than 20 times normal of SGOT, you have to think of hepatic causes like medications or toxin if it is coming with an alcohol-associated liver injury or an acute rhabdomyolysis. These are the conditions where you get very high SGOT values. Now, understanding the AST-ALT ratio is very important. Like I said, in acute muscle injury, the SGOT will be more than PT, so automatically the ratio will be high. Whereas in chronic muscle disease, you can see that the ratio has come down. This is because the SGOT has got a very short half-life. In alcohol-related liver injury, it can be 2:1 or even 3:1. Viral hepatitis or NAFLD, the ratio will be less than 1. And cirrhosis, as I said, SGOT might be more than SGPT. So whenever you get elevated transaminase, always confirm it once again. Assess the history, look for any medication because these are the common offenders. It can be any indigenous medicine, any Arishtam Kashayam, or anything the patient is taking. Antibiotics, statins, most commonly NSAID, anti-epileptic drugs, alcohol history. Rule out muscle diseases and investigate common liver disease because common things are always common in medicine. Now coming to the next is marker of cholestasis, that is alkaline phosphatase. Alkaline phosphatase, what we have to know is it is not only coming from the liver. It can be in the bone, kidney, but most commonly liver and bone. So you have to know whether it is coming from the bone or from the liver. So how do you know if it's coming from the liver? If the other enzymes, the aminotransferases are also rising, we can see that it is coming from the liver. Just confirm it with the GGT also. So if the elevated ALP has an elevated GGT, it means the origin is in the liver, otherwise it's in the bone. So rule out non-hepatic causes first. That is in children, adolescents, growing age, third trimester of pregnancy. After a fatty meal, the intestinal ALP can increase. High bone turnover conditions like growth, healing fractures, vitamin D deficiency, Paget's disease, etc. So once you have focused onto the liver, our aim is to rule out whether it is an extrahepatic cause or an intrahepatic cause. So extrahepatic more common causes are choroidocholithiasis, malignant obstruction, strictures, infections. Intrahepatic causes, the most common ones are drugs and toxin like rifampicin, erythromycin, primary biliary cholangitis, cholestasis of pregnancy, infiltrative disorders, lymphoma, malignancies. So rule out physiological cause first, and they'll usually have an ALP rise less than 2 times the upper limit of normal. So then you focus on to bone. So bone, as I said, the common conditions, growth, osteomalacia, etc. And when you get a very high pathological increase that is more than 4 times upper limit of normal, then you have to think of whether it is an intrahepatic cause or an extrahepatic cause. Then you can do an ultrasound. That is the only area, that's the only time when you need to go for an imaging. So when you do an imaging, you see extrahepatic biliary radical dilatation. Whereas in intrahepatic cholestasis, there will be no biliary radical dilatation, and then you have to go for other biochemical tests. Now coming to other markers, like I said, GGT. GGT, it arises in parallel to alkaline phosphatase, and it helps in distinguishing liver from bone origin of ALP. Now coming to bilirubin. Hyperbilirubinemia is another common thing we come in our practice. So our first aim is to differentiate whether it is a direct hyperbilirubinemia or indirect. So total bilirubin, we all know 0.2 to 1.5, 80% is indirect and only 20% is conjugated. So you can approach as whether it is an unconjugated hyperbilirubinemia or a conjugated. So unconjugated, think about 3 common causes: hemolysis, ineffective erythropoiesis, drugs. After you have ruled out that, the common condition is Gilbert syndrome. So in asymptomatic patient who is coming with a mild unconjugated hyperbilirubinemia, rule out all those things, go with a normal transaminases and alkaline phosphate. The next possible diagnosis is Gilbert syndrome. And in Gilbert syndrome, the unconjugated bilirubin usually does not go very high. It will be usually less than 3. And you get a history of any stress or fasting which has increased the bilirubin level. So this is a summary of what I've said. Just go focus on the last line. If the persistent elevation is otherwise unexplained, is symptomatic, is worsening over time, then you have to consider liver biopsy or other tests. Conjugated hyperbilirubinemia, the approach is same as extrahepatic cholestasis and intrahepatic cholestasis. We'll focus on to the last 2 slides. You go with an ultrasound. If the ductal dilatation is present, you focus on to ERCP or MRCP. And if there is no ductal dilation, there are other possibilities like primary biliary cirrhosis, cholangitis, etc. And then you have to go for AMA test and all. So if the persistent elevation is otherwise unexplained, the patient is symptomatic and it's worsening over time, you have to consider liver biopsy. Now coming to markers of function, albumin, low levels indicate hepatocellular dysfunction, but they can be also low in malnutrition, protein-losing enteropathies, etc. And albumin, it is not very useful in acute liver injury. Whenever you see a low albumin, in a hepatitis case, just a chronic process. So it's an excellent marker in chronic liver disease. Now coming to prothrombin time, you all know the post-translational modification of vitamin K-dependent factors occurs in the liver. So whenever there's an acute liver injury, the prothrombin time increases. So the limitation of PT-INR is it is useful in acute liver disease, and it has got prognostic value in conditions like paracetamol toxicity, alcoholic hepatitis, and NEFLD. So my conclusion is LFTs are definitely essential for diagnosing liver injury, but their interpretation always require a comprehensive approach. Always you have to take the full clinical picture of the patient, including the history, medications, and imaging. and elevated levels should always be interpreted as a battery and not as a single test. And do not go behind values and ratios. Thank you.
Thank you, Dr. Mamta, for that lucid presentation. We are moving on to the next session on osteoporosis by Dr. Sangeeta. She's a consultant family physician at Arvitura Medical Center, Masliva Medicity, Pala. Over to Dr. Sangeeta.
Morning. So, osteoporosis is the most common bone disease in humans. Its prevalence ranges from 29% to as high as 62%. Though the disease is so common, it is oftenly undiagnosed and also, or most commonly untreated also. So, what is osteoporosis? It's a chronic progressive metabolic skeletal disease which is characterized by low bone density along with microarchitectural deterioration of the bone tissue, thereby causing increased susceptibility to increased bone fragility and susceptibility to fractures. Bone is actually active living tissue which is getting renewed constantly. So all bone tissue is broken down by osteoclasts through resorption, and the new bone is formed by osteoblasts through formation. The entire process is called bone turnover or remodeling, so that the entire adult skeleton is getting renewed every 7 to 10 years. The balance between the bone formation and the breakdown, it is different at different stages of life. So, when we look into the graph, the peak bone density is reached in our mid to late 20s. Thereafter, from the age of 40, bone starts to be broken down more quickly than it is getting replaced, so that the bone loses the density. For men, lose the density at a rate of 1% per year, whereas for females, it is at the rate of 5% post-menopause, making it common in women. So there are two types, primary and secondary. Primary is actually most commonly age-related and hormone-related, whereas secondary, it is due to other factors which predispose to bone mineral density, which I will explain later. The risk factors include advanced age, female sex, lack of estrogen, low body mass index, heavy smoking and drinking, diet low in calcium and vitamin D, previous fractures and positive family history. Certain medical conditions like hyperthyroidism, hyperparathyroidism, diabetes, liver and renal disease can all predispose to osteoporosis. Among the drugs, most common cause is the prolonged use of glucocorticoids for more than 3 months. Other drugs include long-term use of antidepressants, lithium, heparin, chemotherapeutics, etc. So actually, this is incidentally detected. Usually first detected when someone present with a low impact or a trivial trauma fractures, especially of the hip, spine and the wrist. Sometimes the patient may present with chronic back pain or height loss or bone deformities as kyphosis. Who should actually be tested? All women 65 years of age, regardless of risk factors. And postmenopausal women if they are present with risk factors, and younger postmenopausal women with risk factors. In males, if they are more than 70 years or more than 50 years with risk factors. Then, dual energy X-ray absorptiometry, DEXA scan, which measures the bone mineral density, is the diagnostic test for osteoporosis. It is expressed as grams per centimeter square of calcium per square centimeter of the scanned bone. BMD of hip and spine are actually used to establish and confirm the diagnosis of osteoporosis, to predict the future fracture risk and to monitor the patients. Two scores are derived from the DEXA scan, that is T-score and Z-score. T-score is used for postmenopausal women and men more than 50 years. So, if the T-score is less than or equal to minus 2.5, then some patient is having osteoporosis. The Z-score is used for younger age group people, and if the score is less than minus 2 standard deviations, then it is defined as low bone mineral density for the chronological age. Another diagnosis test is vertebral imaging. Radiographically confirmed vertebral fractures, irrespective of the bone mineral density, are diagnostic of osteoporosis. This is actually used when somebody present with osteopenia in DEXA scan, or if they having new back pain, height loss, or they are on prolonged glucocorticoids. And the tests like biochemical bone turnover markers, both formation and resorption markers are available, which provide information on fracture risk independent of the bone mineral density. In untreated patients, these are used to assess the rapidity of the bone loss. But in treated patients, this can be used to monitor the response to the treatment. And there is a screening method, FRAC score, that is Fracture Risk Assessment Tool, which is actually a WHO-based questionnaire and assess a person's 10-year probability of a hip fracture and the 10-year probability of the major osteoporotic fracture. So, if the score is 3% or more for the hip fracture or 20% or more for the major osteoporotic fracture, then the person needs further investigation or treatment. And there are additional tests like X-ray, CT, ultrasound, MRI, which are useful for the diagnosis of osteoporosis. So before going to the treatment, first the patient should be evaluated to rule out any secondary cause of osteoporosis and to detect if this patient is having any contraindication for the treatment. The basic tests are complete blood count, ESR, calcium, vitamin D, liver and renal function tests, phosphorus, magnesium, thyroid function and parathormone. And there are other few tests which are done only if you are suspecting secondary causes. So, the non-pharmacological treatment, first of all, is smoking cessation. That is, smoking decreases bone mineral density at all sites. And second will be moderation of the alcohol intake. Then third, multi-component exercise program with weight-bearing, resistance training and balance training exercises. And for elderly, false risk assessment and prevention for the factors causing falls, sunlight exposure and dietary modifications. Dietary modification mainly reduce caffeine intake, calcium and vitamin D supplementation. Pharmacological treatment are indicated in postmenopausal women and men more than 50 years presenting with hip or vertebral fractures, T-score positivity or FRAC score positivity. There are two groups of drugs which can be used for osteoporosis, that is anti-resorptives and anabolic drugs. Anti-resorptive bisphosphonates are the first-line pharmacological drug which is used for both prevention and treatment of osteoporosis. Main groups are alendronate, ibandronate, residronate and zoledronic acid. Main advantage of bisphosphonates is that the effect lasts even if we have stopped the drug. Most common side effect is GI ulcerations and perforation, so that anybody having upper GI disease, this drug is contraindicated. Another drug is calcitonin, which is used as 200 international units as daily nasal spray. The third group is denosumab, which is a human monoclonal antibody, which is given in dose of 60 mg per ml subcutaneous injection twice yearly. Raloxifene is used in the dose of 60 mg per day orally, but is contraindicated in patients having venous thromboembolism. Estrogen replacement therapy, though FDA approved, is not currently recommended as first line. Teriparatide, which is the only anabolic drug, is given as a dose of 20 micrograms subcutaneous injection daily for 6 months, but it is contraindicated in patients at risk of osteosarcoma. And duration of the treatment must be individualized. We can consider discontinuing bisphosphonates after 3 to 5 years, depending upon if the patient is in low risk category. Each visit, we have to assess the treatment complaints and counsel on the risk factor reduction. That is, non-pharmacological measures should be emphasized at each and every visit. DEXAs can be repeated every 2 years to assess the serial assessment of the bone mineral density. Biochemical bone turnover markers can be used if you are using the drugs to assess the response. And vertebral imaging can be repeated if the patient is having height loss, new back pain, postural change, or a patient on temporary cessation of drug therapy. Finally, role of physical medicine and rehabilitation, that is, weight bearing, resistance training, and balance training exercise should be encouraged to improve the bone density, reduction of risk factors, and improved stability. Correct underlying deficits and prevent falls. Though avoid forward bending and exercise with trunk inflection. Trunk orthosis like back brace, corset can be used if the patient is having acute vertebral fractures or chronic pain with multiple fractures. Effective pain management should be done with physical, pharmacological and behavioral techniques. And those with recent painful vertebral fractures who failed on conservative management are candidates for surgery like kyphoplasty and vertebroplasty. Thank you.
Thank you, Dr. Sangeeta. So the next speaker will be Dr. Roshna Abdul Shukur. She will be talking on asymptomatic fibroid uterus. Dr. Roshna is a consultant family physician at Apollo Family Health Center, Kannur.
Good morning to one and all. I will be dealing with asymptomatic fibroid uterus. When it comes to fibroid uterus, it's very easy for us regarding the management in terms of what is the surgical management, medical management, so on. But when it comes to a proper decision making, when our patient comes to us and asks whether this fibroid uterus require any kind of intervention. So my main focus is on asymptomatic fibroid uterus, which is usually detected in routine ultrasounds, which doctors practicing in the MHCs will be seeing it very much occasionally. So, uterine fibroids are the most common benign tumors in women of reproductive age and may be asymptomatic in around 75% of the patients. Only 25% of patients will present with some sort of symptoms. And the major risk factors include early menarche, that is menarche less than 10 years, family history of uterine fibroids, a high BMI, and nulliparity. Now, how do we diagnose uterine fibroids? Mostly when the patient presents with symptoms, it is easy. However, when the patient don't have any symptoms, it is a pelvic ultrasound, that is a TVS or transvaginal sonography, which is picking up the uterine fibroids. And it is the most accurate investigation rather than the transabdominal scan. Now, regarding management option for asymptomatic uterine fibroid. Expectant management, that is waitful watching with periodic evaluation of the fibroid is recommended in most of the cases with an annual ultrasound, preferably the transvaginal sonography. And when we see the size of the uterine fibroid exceeds 14 weeks, the size is comparable to a gravid uterus with 14 weeks of gestational age. In that case, we need to intervene. That is, actually, we have to counsel our patient regarding the different options available. Being asymptomatic, for them, we can even go for medical management, which will be more comfortable for the patient. And also, for patients whom the surgical fitness is not obtained also, we can go for the pharmacological management. Now, what with expected management we aim is, we have to follow up the patient. And that is like annually we can follow up with the TVS. And how, what is the kind of follow-up required depends on the age of the patient also. This is an algorithm. We can see that this is obtained from the FOXY initiative, key practice points. So in this flowchart, I'm looking towards the left-hand side. We can see asymptomatic fibroids usually diagnosed incidentally. If the uterine size is less than 14 weeks in size, it is the expected management, which I already told is an annual TVS. Now, if it is more than 14 weeks of size, there is a mistake there. If it's more than 14 weeks in size, we have to discuss option with the patient, which is the pharmacological and the surgical options. And this will vary depending upon the age of the patient also. Now, when we consider postmenopausal women, we know usually following menopause, if there was any kind of fibroids, they will usually shrink in size. So we don't do anything much for them. However, periodic evaluation should be undertaken to exclude sarcoma, which is around 1 to 2% seen in postmenopausal age group, with high risk factors which we already discussed, like nulliparity, high BMI, or maybe this patient was having an ultrasound which never showed a fibroid in the past, and now in some following checkups or something, maybe around after her menopause, like 2-3 years, we are seeing an enlarging pelvic mass, which is a newly seen fibroid. So in that case also, we have to do periodic evaluation. However, the criteria change if there is a very much fast growing mass and all, which is suggestive of the 1 to 2% chance of sarcoma. So in such cases, we will go for surgical management rather than medical management, because our aim is to identify whether it's a sarcoma. Now, what is the indication of surgical management in asymptomatic fibroid? So hysterectomy is often offered in asymptomatic enlarging fibroids after menopause when there is a suspicion of malignancy, as I already discussed. That is mainly for ruling out sarcoma. Now, myomectomy is done when when a female of reproductive age planning for pregnancy or she is facing a fertility issue. Fertility issue not always come out as a symptom. It can present as asymptomatic fibroid also. Means they may not have identified that they are facing fertility issues. So in such cases, the myomectomy procedure will help them. And that depends, what kind of myomectomy we are going to do depends on the site of the fibroid. For submucous fibroids alone, we will always plan for hysteroscopic myomectomy. Now, if in case a pregnant, for reproductive age woman undergoes myomectomy, she can plan her pregnancy after 3 months. Till then, she have to use the contraception. Now, there are certain exceptions for expectant management of symptomatic women. That is a woman with a hysteroscopically resectable submucous leiomyoma, even though she is not having any symptom, if she is planning pregnancy in future, there is a higher risk of miscarriage due to the submucous fibroids. So for her, we have to do an intervention, even though she is asymptomatic. Secondly, a woman who presents, like a woman comes and her ultrasound reports are okay, means there are multiple uterine fibroids. Along with that, she's having some moderate or severe hydronephrosis. This usually happens in case of a broad ligament fibroid like that. So in such cases also we have to intervene, even though she is asymptomatic, because in future she can have renal dysfunction if the hydronephrosis progresses. Now, some pharmacological agents which we can use. This is a levonorgestrel intrauterine system. It is useful for mainly symptomatic fibroids alone. However, asymptomatic fibroids, multiple fibroids, which is like around 40 years, and they may achieve menopause maybe in 5 to 6 years. In that case, we can use this to shrink the size of the fibroid. In practice, we usually give only for menorrhagia, usually, but it can also be used for shrinking the size of the fibroid. And it is the best choice in women who have with a symptomatic intramural myoma who do not desire pregnancy, because it also provides contraception. Now, ulipristal acetate is a selective progesterone receptor modulator. The preoperative treatment of women with fibroids, it helps in that. It helps shrink the size so that the procedure becomes easier. And this can also be given in women who has got an gravid uterus more than 14 weeks. In such case, we can advise them, if she is approaching menopause maybe in 3 or 4 years, she can be on this medicine, and we can watch for if there is a shrinking size of the fibroid. In that case, the dose used is 5 milligram daily for 13 weeks. This is considered as a single course, and this is usually given if it is more than 14 weeks and she is asymptomatic. However, if a woman is having menorrhagia and we are treating with this kind of medicine, means we can give such 3 courses maximum. Otherwise, we have to go for surgical management, because the patient will be losing blood and she will develop anemia and so on, other complications. Now, mifepristone is another drug which we can use, and usually the starting dose is 25 milligram daily for 3 months, and a maintenance dose of 10 milligram daily is recommended thereafter. Now, we will move on to the MCQ section, and in this, I'll read out. A 58-year-old woman who is a para-0L0 with no symptoms attained menopause 3 years ago was found to have an intramural fibroid with the uterine size corresponding to 9 weeks of gestation in routine ultrasound checkup. Her old ultrasound reports were normal. As a family physician, what is the best advice you can give to the patient? Can anyone try to answer? She achieved menopause 3 years ago, and past reports are normal. Now we are seeing a new mass. So in this case, expectant management should not be done. We have to discuss various surgical options of management. Why? Because it's postmenopausal woman, a new enlarging mass. There is no point in doing medical, because our main aim is to find out what is enlarging mass. So we have to discuss the various surgical options of management. Second question. A 44-year-old female visited your OPD regarding concern of her recent scan reports. It showed multiple intramural fibroid, the largest measuring 3 centimeter. She didn't have any kind of complaints. As a family physician, what is your advice? She is asymptomatic. It is corresponding to like multiple fibroids, and she don't have any complaints. So we can do expectant management for her. Okay, that is an annual follow-up with the TVS. 44 female, you visited your OPD with concern regarding ultrasound report, and we can see multiple fibroids, intramural fibroids, and moderate left hydronephrosis. However, on asking, she didn't have any complaints regarding the same. As a family physician, what is your advice? Can someone tell? Yes, we have to refer to gynecologist for surgery because we know tomorrow or so on, the hydronephrosis can worsen. The last question. A 29-year-old woman, anxious to conceive, underwent hysteroscopic mammectomy as part of her fertility treatment. You're her family doctor. She approached you for contraception. How long should be the contraception taken? Yeah, 3 months. So that's all about the topic. Thank you.
Thank you, Dr. Roshna, for explaining this topic. And now we move on to the last topic in the bullet session, that is approach to thrombocytopenia. To speak on this topic, we have Dr. Rabia. She is a consultant family physician in Kerala Government Health Services. Over to Dr. Rabia.
Good afternoon. So my topic is approach to thrombocytopenia. Normal platelet count ranges from 1.5 to 4.5 lakhs per microliter of blood. And thrombocytopenia is considered when it is less than 1.5 lakhs. And there are various causes of thrombocytopenia. It includes decreased production, increased destruction, and splenic sequestration. And decreased production due to B12 and folic acid deficiency. Then many of viral and bacterial infections cause like dengue and measles, chemotherapy, radiation, alcohol and drugs, and aplastic anemia, myelodysplasia, hematologic malignancies, and hereditary thrombocytopenias. Increased restriction due to immune causes include drug-induced thrombocytopenia, immune thrombocytopenic purpura, connective tissue diseases, heparin-induced thrombocytopenia, HIV, and post-transfusion purpura. And non-immune causes include DIC, thrombotic thrombocytopenic purpura, and hemolytic uremic syndrome. And increased splenic sequestration in case of splenomegaly conditions like hypersplenism, CML, and lymphomas. And these thrombocytopenia causes bleeding disorders. And how can we differentiate a bleeding disorder from a coagulation disorder? In bleeding disorders, they cause skin and mucous membrane bleeds with petechiae purpuras. And while coagulation disorder causes deep soft tissue, joint, and muscle bleeds. And in bleeding disorders, the ecchymotic patches are superficial, small, and multiple, while they are single, large, deep in coagulation disorder. And bleeding after minimal trauma is common in bleeding disorder, while rare in coagulation disorder. Bleeding immediately following surgery is common in bleeding disorder, while delayed and often severe bleeding seen in coagulation disorder. So with this, we go to a careful history taking. History of fever in infections and even leukemias can present with fever and thrombocytopenia. History of rashes, jaundice in case of CLD, hepatitis B and C, joint pain and recurrent abortions in connective tissue diseases, history of diarrhea, and history of symptoms of other cell involvement like features of anemia or recurrent infections. Then bone pain in case of hematologic malignancy, a careful dietary history which suggests B12 and folic acid deficiency, recent drug and immunization history, alcohol use, and risk factors of HIV, hepatitis B and C. Then family history of thrombocytopenia, pregnancy status of the patient, transfusion history, and recent heparin exposure. And on examination, we note causes petechiae and purpura. Wet purpura or blood blisters in the oral cavity suggest severe thrombocytopenia and impending bleed. Then joint and soft tissue bleeding suggests coagulation abnormalities. Look for nutritional deficiencies like pallor, neckle pigmentation, which suggests B12 and folic acid deficiency. Pallor, apart from nutritional cause, it also indicates bone marrow infiltrating conditions and severity of bleeding. And it's also seen in CLD. And CLD, you can see icterus, clubbing, edema, and skin and hair changes of CLD. Then oral cavity, look for bleeding spots, gum hypertrophy, tonsillar enlargement. Look for sternal tenderness, lymphadenopathy, and hepatosplenomegaly, which suggest hematological malignancy. So when we see thrombocytopenia, first rule out spurious thrombocytopenia because platelet clumping is commonly associated with EDTA-dependent agglutinins. So we have to repeat the sample in an heparinized sodium citrate sample. Then it may be normal for the patient because the normal values encompass only 95% of population. And look for the other cell involvement. If the total count and hemoglobin are abnormal, carefully examine the RBC and WBC features which indicate a bone marrow involvement. And is the patient pregnant? Pregnancy can be associated with 9% of pregnancies can have gestational thrombocytopenias, which are usually asymptomatic detected late in pregnancy, not associated with any fetal thrombocytopenia or bleeding risk. And one of the common causes in our OP setting is drug-induced. It usually occurs within 5 to 7 days of exposure to drug, but as fast as within hours if the drug is previously exposed, and usually resolves within 7 to 14 days after discontinuation, and the counts can reach up to 20,000. And many drugs with various mechanisms can act. Some of the common drugs are penicillins, cephalosporins, even paracetamol, amlodipine, fluconazole, heparin, everything can cause thrombocytopenia. And thrombocytopenia may be seen in 76% of CLD patients. It's usually a persistent thrombocytopenia. So abstinence from alcohol intake and nutritional replacement lead to normal platelet count in the absence of CLD. And a careful dietary history. If the patient is a strict vegetarian with deficient in proteins and vegetables, indicate B12 and folic acid deficiency, along with contributed by use of alcohol, or patient may be taking metformin. It can present with anemia or thrombocytopenia, and even pancytopenia with elevated MCV, and the counts can reach up to 40,000. And look for risk factors for HIV, because it can be initial manifestation 10% of patients. And in pediatric age group, consider congenital thrombocytopenia. It may be go undiagnosed until old age if it is mild. And consider immune thrombocytopenia. It is acute immune mediated in the absence of no other causes, and it is isolated thrombocytopenia. That is, it's a diagnosis of exclusion. It can be idiopathic or secondary to other causes like HIV, SLE, H. pylori, or drugs. So the tests are basically to rule out the secondary causes, and the treatment depends upon the severity. And the red flags include presence of blast on the blood film, evidence of hemolysis, recent use of heparin, and associated coagulation abnormalities. So when we see thrombocytopenia, look for the hemoglobin and white blood count. If they are abnormal, go for bone marrow examination. And evaluation based on peripheral smear. If there is platelet clumping, suspect a spurious thrombocytopenia, and repeat. In true thrombocytopenia, if there are giant platelets, considered congenital thrombocytopenia. If there are schistocytes or fragmented RBCs, consider TTP, DIC, or HUS. If there are blast or nucleated RBCs, consider primary bone marrow disorder and do a bone marrow aspirated biopsy. If there are microspherocytes, consider Evans syndrome, that is autoimmune hemolytic anemia with thrombocytopenia, or hypersplenism conditions. If there is lymphocytosis, atypical lymphocytes, neutrophilia, consider infections causing thrombocytopenia and appropriate workup. If it is isolated thrombocytopenia, it is then considered ITP, drug-induced, and investigation based on clinical assessment. So the investigations are peripheral smear, bone marrow biopsy, liver functions test, very important to rule out CLD, then autoimmune etiology if we suspect, then ANA, and viral studies, hemolytic screen depending upon the history and examination. And management depends upon the symptoms and severity of thrombocytopenia and the underlying condition. Meanwhile, correct nutritional deficiencies, avoid or stop drugs causing thrombocytopenia, avoid contact sports and rough physical activity, avoid aspirin, NSAIDs, intramuscular injections, and other invasive procedures should be deferred, and platelet transfusions only in life-threatening conditions. So the red flag signs, those with red flag signs and severe unexplained thrombocytopenia, we have to refer. And most of the patient can undergo in our, if the count is less than 10,000, they should be restricted from contact sports and other traumatic activities. And most surgical and invasive procedures can be performed if the counts are more than 50,000, except in neurosurgical procedures. So as family physicians, we should identify the common causes First, rule out spurious thrombocytopenia, consider infections causing, then contributed by B12 and folic acid deficiency, chronic liver disease, then only think about other causes like autoimmune, ITP, finally if there is no other cause, and avoid unnecessary investigations, correct nutritional deficiencies, and serious causes to be identified early and referred promptly. So treat the patient and not the count. Thank you.
Thank you, Dr. Rabia. That brings us to the end of the bullet sessions. Thank you all speakers for that short and crisp presentations on incidentally detected conditions.
We have come to the end of a very informative session on incidentally detected asymptomatic conditions. I invite Dr. Rashmi to give away the mementos to the speakers. Dr. Fahmi K. Dr. Joyce Joseph. Dr. Mamta Manohar. Rest of the mementos to be handed over by Dr. Vishnu. Dr. Roshna Abdul Shukur. Dr. Rabia Kuri. Dr. Sangeeta. Thank you. Now I invite Dr. Anand K., Advisory Board Member, AFPI Kerala, Specialist Family Physician, to hand over the mementos to the chairs. Dr. Rashmi Saimal. Dr. Vishnu. Thank you, sir.
Next, we have a panel discussion. It's a spice route session on of AFPICON Kerala 2025.
Okay. I invite on the dais Allied Medicare team, Dr. Prafulla TP and Dr. Bhavyashri TN, who conducted an enlightening workshop on USG guided procedures. I request Dr. Mansoor, organizing chairperson AFPICON 2025, to hand over the mementos to the team.
Thank you, Dr. Bhavyashri and Dr. Prafulla, for traveling all the way from Bangalore to conduct a workshop on ultrasound guided procedures here at AFPICON Kerala 2025. I request each one of you in this audience to give them a big hand. And this is Dr. Prafulla. Actually, she's a native of Thalassery itself. You can contact her if you require anything regarding these bugs. They are conducting a module like basic ultrasound guided skills bugs. Actually, we couldn't give hands-on to everyone here. We have restricted the workshop to 20 people only. We know everyone required the same. If you want to have any workshop in further coming months or years, you can contact Dr. Prafulla. She will be here during the lunchtime for the next half an hour or so. Or otherwise, you can contact the organizing committee. Thank you all.
Lunch scheduled at 1 p.m. at the restaurant and the lawn area.
Next, we have a spice route session. I invite Dr. Vishnu to moderate the session on global perspective on primary care.
So I'm welcoming you all to the Spice Route session for AFPICON Kerala 2025. The topic we have chosen for this session is Global Perspectives in Primary Care Experiences from Across the World. So we have chosen speakers from various parts of the world, especially the South Asian countries. And the first speaker will be Dr. Sangha Nandanikumara. He is a family physician and GP educator from Sri Lanka with extensive experience in primary care systems across the globe. He is an immediate past young doctor lead of WONCA, the World Organization of Family Doctors, and honorary secretary of WONCA South Asia region. Over to Dr. Sangha, who is the co-chair of World Special Interest Group on Policy Advocacy and the chair-elect of WONCA Working Party of Planetary Health. Over to you, Dr. Sangha. Just a minute, your audio.
Lovely. Let me share the screen first.
Yeah.
How's it? I think it's visible.
Yeah, visible.
Thanks. Okay, dear colleagues, Thank you very much for inviting me to this session of the AFPI Kerala conference.
Dr. Sir, just a minute.
Yeah, sure.
Yeah, you can start now.
Thanks.
You can start now.
Yeah, sure. Let me just. Okay. So thank you very much, colleagues, for inviting me to this session, which is organized by the Spice Route, to talk about the global perspective in primary care, to share our experience from different countries across the globe. I would say I have very fond memories about Kerala in 2020 when I traveled to Kerala for my fellowship in palliative care in Institute of Palliative Medicine. In February, just before COVID outbreak. And as you can see, I had a very, very nice time with my palliative care colleagues, as well as some familiar faces to you, as you can see, who hosted me, the friends who hosted me, and more than friends, they were like family to me. So I'm sad that I could not be with you at this moment, but I hope that soon, probably next year, I could be with you in Kerala for the next conference. I would like to talk about what about primary care first. What is primary care and why primary care is important, and why family doctors and the family doctor system is important, and then about the primary care systems in different countries, and also then about then let's discuss about the next steps. I was in the Wonka executive from 2021 to 2023 as the Young Doctors Lead. So that was the time where I had the opportunity to travel around the world most of the time. I mean, doesn't mean only that time, but from 2016, where
Recording in progress.
From 2016, where I was involved in Wonka activities, I had opportunities to go around the world, but it was more when I was in the executive. In many countries, in Europe, in Latin America, in Middle East, Australia, and also the East Asia. So by traveling to all these continents, I got some first-hand experience on primary care in these countries. So which I think rounded me and shaped my perspectives and my vision as well in primary care as well as family medicine. So what is primary care? I would just go to the definition in the Wonka guidebook. It says that it is a part of a health services system that assures person-focused care over time to a defined population, accessibility to facilitate receipt of care when it is first needed, comprehensiveness of care in the sense that only rare or unusual manifestations of ill health are referred elsewhere, and coordination of care such that all facets of care, wherever received, are integrated. So you can see these bold words, and you can always think about the principles of family medicine with that. So when you take that is primary care. We have to be very, very particular about the differences between the primary care and the primary health care. Primary care is part of primary health care. Now you can see on the screen the definition of primary health care according to the Alma-Ata Declaration. So this also encompasses the primary preventive care, which is public care. So primary care is more about primary curative care, and which is more closer to family medicine. If you go through the principles of family medicine, and if you go back to the definition of primary care, you can understand how close these two are. So it's about first contact care, continuity of care, comprehensiveness, patient-centered coordination, and also health promotion and disease prevention, and based in the community. So, who is a family doctor? Now, you know, ideally, a family doctor should be a doctor with a training in family medicine or general practice. And the name could be used in different ways, like family physicians or general practice. The term general practice practitioner is usually used in some countries like the UK, Ireland, Australia, New Zealand, and Europe, etc. Even though we use the word family physician because of some reasons, because the main reason is that in our part of the world, the private practitioners or untrained doctors with MBBS or the basic medical degree also practice in the community as so-called general practitioners without a qualification. So we used to not use the word general practitioner in this part of the world to the qualified family doctors, even though in UK, Ireland, etc., as I told, they use the word general practitioner to qualified doctors. So it's different. That is the difference, but different terms are used to the same people, to indicate the same people, same name. And why we need a family doctor system? Because impact of primary care on health outcome is well proven in different contexts. And probably you know this lady. Do you have any idea about this person? That is, as you know, Barbara Stafford, who did extensive research and provided evidence for the importance and the impact of primary care on health outcomes, better health outcomes. And she's not a family doctor. She's a pediatrician from USA. So if I quote from some work by Barbara Stafford, you can see the rationale for benefits of primary care for health. One of her articles, with some of other authors, provided how primary care is benefiting the system or the society, like by greater access to needed services, better quality of care, a greater focus on prevention, early management of health problems, the cumulative effect on the main primary care delivery characteristics, and the role of primary care in reducing unnecessary and potentially harmful specialist care. So the importance of primary care is proven more or less by providing well-established evidence. And not only that, this paper is the ecology of medical care revisited. The first paper published in 1960s by White et al., which was revisited by Green et al. Later in 2001. You can see from the graph, it shows only a few get admitted to hospital out of the vast majority seeking medical care, compared to the high number seen by primary care doctors. So the burden in the society for diseases or illnesses are being primarily handled by the primary care doctors, the family doctors. So if you go to a tertiary care hospital or a teaching hospital, you will see only one patient out of 1,000 people in the society who are prone to get an illness or who have some illness or some symptoms. So majority is being handled by primary care doctors or family doctors. So the burden to the system is reduced by primary care doctors. And now I would like to talk about the countries, some of the countries, the systems. The different countries have different primary care systems. I would like to start with my own country. Sri Lanka, which has a 21 million population, which has a healthcare system, free healthcare system, tax-based, with some private healthcare components. But as in India and most of the South Asian countries, we don't have an established DPP system. So in Sri Lanka, the state primary care, or give me a second. Sorry. Yeah, in Sri Lanka, the state primary care is run by either outpatient departments in big hospitals like secondary and tertiary care hospitals, and also we have something called primary medical care units and divisional hospitals, which have more primary care related services. So this is a state primary care. But the majority or the major portion of primary care is handled by the private sector, where more than 55% of first contact care, according to research, is handled by general practitioners. This has so-called general practitioners as well, trained family doctors, as well as untrained MBBS graduates who have been allowed legally to practice in the community. So the number of family doctors with training are around 1,000, and there are more than 8,000 private practitioners who have got no training in family medicine. So you can see the majority of the patients are handled by private sector, and even government sector or private sector, majority of family doctors do not have a training in family medicine. So this is the system. However, patient can see specialists directly in private sector, which means there's no referral system, just as in many of the other countries in South Asia. So if I talk about the family medicine programs, the postgraduate programs, in Sri Lanka, we have the MCGP, Member of College of General Practitioners, MD and DFM. The MCGP enrolls around 50 to 100 trainees a year, which is run by the College of General Practitioners of Sri Lanka. And the doctors, this is for the doctors who are in the community, and most of the doctors go back to the community after the training. In contrast, the MD in family medicine, which takes only about 15 doctors per year in their intake, which is run by the Postgraduate Institute of Medicine. These doctors who pass out after the post-graduation will go back to the government hospital, OPDs, or academia. So the problem in Sri Lanka is mainly about the capacity in the family medicine postgraduate programs, which is difficult to handle at the moment. We are not providing the adequate numbers of family medicine trainees or qualified family doctors at the moment, because it is not necessary at the moment to have a family medicine qualification to practice in the community. Then I would like to go to another country, which out of some of the countries I visited in Latin America. I think most of the countries have a similar system. I would like to talk about Colombia, where they have 50 million population. Health is run by universal compulsory health insurance system. With the insurance system, it is open to anyone. Again, just like our region, there's no GP system, and number of qualified family doctors are only 1,200 to 50 million population, which comes to the family physician patient ratio of 1 to 4,200. But there are, just like our general practitioners, there are some general physicians practicing as private practitioners in Colombia who are known as general physicians. They are around 43,000. So you can understand, again, the same story just as our countries. Many untrained family doctors or primary care physicians are practicing in the community. The qualified family doctors work in the community clinics and in the hospitals, and these general physicians are in the private sector. So in Colombia and most of the Latin American countries, there are family medicine postgraduate programs regulated by the government. Now in Colombia, there are 6 universities which offer postgraduate qualifications in family medicine regulated by Faculty Council of Health Sciences. Just in a similar way, other countries like Mexico, Peru, Argentina, etc., the same thing happens. And as you can see, new family medicine residents who pass out are only about 80 per year. And the population is 50 million, and at the moment, qualified family doctors are only 1,200. The same story. And I would like to then talk about the United Kingdom, where I was based in last 2 years, which has 70 million population with a tax-based free healthcare. That is private sector, but it's very difficult to afford private sector healthcare due to the enormous cost. So most of the people, they tend to go to the state sector facilities, including general practitioners, because it has a fully functioning general practice system under the National Health Services or the NHS. There are 36,500 GPs approximately, mainly paid by the NHS, and each and every person, all residents in the UK, should get registered with the GP in the area. They are provided a few options. They can choose out of them, and everyone should go to the GP for all illnesses except the emergencies. If emergencies, the emergency department or AN is there, and the GPs manage the illnesses, or they refer the patient to the higher level or the specialist clinics. As I told, private GPs and specialists are available, but very costly. Like a consultation would at least cost around £300 per consultation. Very different to our setup. And there are issues. There are less GPs at the moment. GPs from the UK are also migrating, interestingly, and there's increased workload, which has increased the waiting time in the general practitioner, for general practitioners in the United Kingdom. If you talk about the training in the United Kingdom, the training is mainly by the Royal College of General Practitioners of the UK. To provide the MRC GP qualification, annually, 3,000 to 4,000 general practitioners are trained inside the United Kingdom. It has been actually increased in the recent years to cater the increasing demand. And you would see, many of us see this as an ideal system, but there are a lot of issues going on. Despite it's being running in a fairly okay manner, there are many problems coming in, which is not visible to outside, but there are many problems inside. And I would like to talk about Norway, which I actually enjoyed one of my visits. Norway is a big country from its land area, but it has a population of only about 5.6 million. And the health is tax-based free health system with some out-of-pocket contributions from the patient side. It also has a fully functioning GP system, which is a bit different from the UK system, where the GPs sign contracts with the municipal council, and municipal councils facilitate the GPs in the area to run their clinics, and they are being remunerated, and the population in the municipal council are assigned to the GPs. Most of the practices are group practices, and each GP would, in GP practice, would have a population which is divided among the GPs in the general practice. And the patients, for basic consultation, there's no need to pay anything, but if the consultation exceeds some limit for their specialist services, for an example, counseling or procedure is offered, then the patient should pay out of their pocket. And the specialist services are accessible only through the GPs, just as in the United Kingdom. And the Norway's GP training is interesting, which is run by the Norwegian Medical Association's College of General Practitioners. The training is mainly community-based, where 400 hours of hospital training is provided, but most of the training is happening in the group practices, where the trainees work in the group practices under their supervisors and get their training. It's very interesting, and I thought it's very sort of practical system where the burden of trainees have been reduced by allowing trainees to work in the system as well. So I only want to, due to time constraints, I would like to tell only about these 4 countries. I talk about Sri Lanka, your neighbor, and my country, and about Colombia, another developing country from Latin America, UK, and Norway. I would talk about some other countries in as well, but 20 minutes would not possible. We can discuss later about this. Some points to ponder. Because I don't want to tell anything specifically from my ideas. So I don't want to give you my ideas, but I would like to tell you, or I would like to request you to think about these things. So if you see the general practitioner system or the family doctor systems in and around the world, you can see developed countries have better systems. And why? We have to think about that. And community-based family doctors systems are more practical and have been more successful rather than hospital-based systems. This is again relevant to the family medicine training, where we get the family medicine training, whether it's a hospital-based training or mainly community-based training. Another thing to think about. So we all agree, I think, the basic medical qualification is not adequate to provide the better primary care. To preserve the quality of primary care, we need some sort of a training in family medicine and general practice, because then only we can provide the primary care needed with a real understanding. I think we all understand that, and we all agree with that. But we need to train more family doctors for this. And how can we do that? Is our system allow us to do that? And how can we think about a better or successful or sort of improved system in future? And then how to convert the so-called general practitioners who are already practicing in the community to qualified family doctors. We can't just ignore the general practitioners or unqualified doctors who are practicing in the community at the moment. What should be done? How can we convert that? What should be the plan for the next 10 years or 20 years? These are the things we have to consider. As qualified family doctors, as people who are in training, who are already qualified, who are in policy making, who are in who are attached or who are working actively in organizations like AFPI have to think about this and importance of pushing governments or advocacy or policy advocacy for a better system, family doctor-based system, a referral system, and how can we do that? What is the role from our side to go ahead with this plan to have a better family doctor system? And don't think that any country is perfect. Just see this notice caught in one of the general practices in the UK. As I told, UK is having problems due to lack of general practitioners and the increased waiting times. And do you think that this is in line with the principles or core values of family medicine? It says that please be aware that the GP will only deal with one problem within one appointment slot. If you have more than one problem to discuss, you will be asked to book another appointment. Long appointments can be booked with the reception when you have more to discuss. So do you think this is in line with core values of family medicine? But this has become unavoidable due to the problems that are in the UK system, due to lack of family doctors, lack of GPs, migration of GPs, despite training 4,000 GPs a year. So don't think any country is perfect. We all can learn from so-called developed countries, but also we can think about our strengths in our region. From each and every country in our region, we can learn from each other. I think one of the main reasons to have such a session, this sort of session, is also to learn from each other and to develop the best way we can go ahead as countries. Each country has their unique systems and unique needs, so we have to abide by those things as well. And I would say all these challenges always open opportunities. So without challenges, there won't be any opportunities. So the challenges we have as developing countries in global south would also open up opportunities, a lot of opportunities. We can learn and we can probably think about fresh systems, because our systems don't have established systems, so we can go for newer, innovative systems with that. So challenges will always provide opportunities. And thank you very much. I would love to take questions after all three speakers. Thank you very much.
Thank you, Dr. Sankar, for enlightening from practices of different parts of the world. Now, I would like to call upon Dr. Anam Eshtia, who serves as a family physician and palliative medicine consultant at Pakistan. She pursued a palliative medicine fellowship at AQ and is currently pursuing masters in bioethics from Aga Khan University. She holds the position of National Chair of Spice Food Pakistan, and her research and clinical focus lies in community-based care and longevity society. Over to you, Dr. Anam.
Thank you so much, Vishnu. I'm not able to share my screen if that's...
Just a minute, I'll make you the co-host.
Hello, everyone, and very good afternoon. Thank you so much, to Spice Route India, for inviting me for this lecture, for this talk. I'm truly grateful to Dr. Vishnu and the whole of Spice Route India. So, I have been given a topic to talk about primary care in Pakistan, reflecting on the progress and embracing the future. And Dr. Sankar has rightfully set up the stage for us to continue on what is happening and where do we see ourselves as a region altogether. So I have no disclosures. In the next 10 to 15 minutes, I'm going to talk about the healthcare system in Pakistan. How did the family medicine or general practice started altogether? The progress we have so far, the current landscape, and what we look forward to. So, like you all know, that we are a nation built having 4 provinces at the first year, 2 more with Gilgit-Baltistan and Azad Kashmir having a separate governance. We serve as 240 million altogether. And Pakistan, out of all the South Asian countries, spends the least on healthcare. That is $38 per capita. By far, we are able to have 1,276 hospitals, which most of them have private sector is increasing with time. Public sector is there, but is connected with the basic health units, which is 5,500 throughout the country. And then we have been able to create 780 maternity and child health centers. Very recently, universal health coverage has been introduced to the country, which is a government initiative in order to provide health as a fundamental right to citizen. So obviously there's a disparity between the urban and the rural, and we see the community health index in the rural setting is 16 times less than what we see in the urban. As we are your neighboring country, we suffer the same problems that India does. We have increasing number of NCDs now. Cancer in the LMIC by 2050 will increase to 400%, which is very alarming. Injuries then account for at least 11% of the total disease burden. We have the highest burden for HCV, and the tuberculosis and HIV rates are going up as well. And the problem that I would really focus on right now, that is my interest, is longevity society. By 2050, 14% of our people are going to be ones aged above 60. And that is going to be troubling because we will be seeing more of NCDs, we will be seeing more of age-related disabilities, and we'll have a much huge burden on our healthcare when we have more people who won't be economically advantaged. Primary healthcare in Pakistan, we by heart and soul owe it to one person, and that's Dr. Professor Riaz Qureshi, father of family medicine in Pakistan, and he has been well-wisher of the field till his last breath. And we lost him in 2023, and we had his first death anniversary last December. And the way he cultivated the field for us, I think we just owe each and every bit of a progress to him. So, reflecting on what has happened when Dr. Riaz came to Pakistan in late 1980s, he established a family medicine department in just one private hospital, which was Aga Khan University, and that because of the leadership invested in primary healthcare. Sooner, we were able to join hands with the CPSP. Now, there's a difference where in Pakistan, we don't have colleges for every other specialty. We have one governing college for postgraduates, that's College of Family Physician, College for Physicians and Surgeons of Pakistan, and all the specialty have to register to that. So that's like our main governing body for postgraduates. getting a 2-year and a 4-year structured program attested by them and accredited by them was a long journey. Then we have had MRCGP International that was introduced in 2006, Pakistan being one of the prime location alongside with Sri Lanka. Then there were universities, and by far I'm just pointing out what private sector has been doing. Till 2018, we did not have government look into the primary health care. So there were other universities in Karachi, Sindh, which joined hands with international collaborators in Canada and started up a diploma which was accepted elsewhere. So we had people attracted towards family medicine as such. 2018 was a landmark. We achieved a great deal. We made it sure that the undergraduate teaching of the PMDC makes it mandatory for the MBBS curriculum to have at least 100 hours of family medicine teaching so that the undergraduates, the medical students get sensitized about what public health and community medicine alongside with family medicine is and what kind of a change that is expected from them in the future. So 2018 also gave a headway to telehealth services in the country. Then one thing that has changed the landscape was also a WHO accredited certification course. It is a 1-year course, and what change it brought is that the people who were not able to uh, complete their postgraduate training or were so occupied with their financial struggle that they could not opt for a training position, they had an opportunity to come back to the force and be a part of the family medicine or general practice. What it enabled them was to bring in that confidence, have a refreshment course, and then they were very involved with the updated evidence-based practices and they started being validated as well. So although they were doing private practices or their clinic practices, but they felt connected to the main academia. 2019 also gave a way to mental health because most of suicidal cases up north is because of increased depression. So mental health program integrating with primary health care actually opened doors for us to talk to the collaborators, the policymakers, the government, so that they kind of understand that at the edge that we are standing, primary care needed to be promoted in the country. Lastly, very recently, the fellowships have been started. So we know that it's just not family medicine, but you need to have a subspecialty. And because of the increasing aging and NCDs, we have started off with geriatric and palliative care fellowships, which are based in primary healthcare. So, like I said, MBBS, we have 100 hours post-internship. Few of the provinces have made it very compulsory for all the young graduates that they have to serve as in a rural setting for at least 6 months before they can have a position in a postgraduate training program. And that has basically increased opportunities for research, for better patient awareness and community engagement as well. Postgraduate training, again, like CPSP, we have 2 years structured training or a 4-year structured training. After 4 years, you're known as a consultant and it gives you a way to enhance into your academia as well as research. For a 2-year structured program, you could either do a 2-year structured program or have 5-year experience in clinical practice and then join the force. But you have to give and pass the exam to have that much of satisfaction that you are a safe doctor and ready to serve in the community. Then, like I said, that the 1-year WHO accredited courses gave way to a lot of people accepting and coming into the primary healthcare field. We were able to increase the workforce and network into a better community. So just in reflection to what Dr. Sankha said, how are we different? We are different because our problems are different. We are different because probably trained, untrained physician is not our problem. Our problem is that we do have quiet sitting at the rural setting, probably having a better clinical practices that we have. We have unsafe traditional healers. We do have, and I'm sure that you all can resonate to what I'm saying. Our problem is to have a better healthcare provision at that end, the community and the rural end, rather than building a much stronger workforce. So being inclusive is one thing that we as a nation and a region can provide so that people do not, we're not hurting their sentiments, but we are also accepting them in the workforce on the terms and conditions that we have, that they have to have a much safer and evidence-based practices. So over the last decade, Pakistan has seen some amazing collaboration. And one is by Dr. Abdul Jalil Khan, who came back to Pakistan in the northwest, the KPK province. And what he did was he started off with collaborating with the government, and then he started hosting seminars and inviting the traditional healers. And his focus was all about getting in touch and not missing a person with mental illness. And that has had a huge impact that people were starting to refer patients to the institute. So much so that last, I think November only, they came up with their own guide for psychosis. So this was a family medicine, primary healthcare in collaboration with a lot of people and their local stakeholders, bringing way to a family medicine guide for psychosis. Now, the other hospital, like probably one of the major network system in Pakistan, which is a quality of care free of cost for everyone. The institution does not have a cash counter, so it is completely based on funding, charity, and donations that they collect. So they got invested in prime healthcare, and under the leadership of Dr. Hiba Ashraf, now the institution operates more than 100 primary care sites. And when I say 100 primary care sites, they are basically connected to the core. It's a hub and spoke model. The hub is Karachi, and then they have 100 sites which are being monitored, which are being regulated and administered by the main Karachi sites. So we have 100 sites, over 300 doctors. Most of them did their post-graduation training and courses after years. They aren't the young ones, but they are the ones who got events that probably being updated, being with the main force, being with an academic institution, gives them much more validation and satisfaction rather than running their own private clinic. Lastly, one of the innovation that our Khan stepped up with was a 2-year rural general practitioner training program. This was, it's different than a typical family medicine training because they are training the locals. They make sure that they are registered to CPSP, they are giving the 2-year exam, and their main focus is alongside with our curriculum. They have added managing emergency medicine, public health crisis, pandemics, and even the community advocacy. So that program in its own has served a greater purpose, and they have graduates for over the last 5 years. They were able to train 50 people. Then very differently, we have had teleclinics for the rural settings, which came in waves from 2018, got a lot of appreciation during the COVID, and post-COVID, it's an established system. Boat clinic, again, an innovation. This boat clinic floats along the Indus River, and it is providing the services to 7 different islands where there's no healthcare and there's no general practitioner or medications are not even available. So this boat is not a static boat somewhere. It's basically traveling, and it has timings and clinics, and they have a full boarded medication pharmacy along with the doctors and paramedics, and they have kits to serve emergency situations as well. Lastly, our need of time is that we create our own guidelines because our diseases, our people, our problems, even the screening strategy needs to be different than the West. So Pakistan, Afghan again created their manual for clinical practice, and out of 200 protocols that they have, more than 50 are for primary healthcare. And I think that has been a huge achievement altogether. LNS, where I serve, we are more towards longevity society. There is a more acceptance towards senior citizen primary care, where people come in, they have been screened for stuff, they spend their time, engage into activities, and then we have a complete home-based palliative care, where a family physician is going towards their places and they're providing end-of-life care, also home-based care for geriatric patients. So altogether, what the barriers and challenges we have so far is obviously insufficient funding. What is being done is out of philanthropy. Private institutions are invested into promoting family medicine. The government has moved an inch, but haven't done much about it. Then we have inconsistent government policy. We have our last government was fair enough to create some really good insurances for people such as Sehat Sahulat, but it did not, it was not sustainable, and then the other government did not continue with it. And then our problem is the traditional medicine that we see in the rural areas. Inadequate workforce, less on focus on preventive health, and then inequitable distribution of resources. Like I mentioned, the urban community health index is greater than the rural one. And lastly, in the coming years, I think people would resonate to this as well. The brain drain is the main problem. Even if we are training family physicians, we are making sure that they get a degree, they are involved in the workforce, they're kind of leaving the country now. So for a better future, for financial stability, but the number of doctors that are being produced, 30% and more want to move out of the country for a more secure future. Way forward, according to, because I'm a huge advocate of regional advocacy, and the South should empower the South. The guidelines we need for our region is a top priority. National level conferences and international level conferences where we can share the progress. Then policy making and government initiative which is sustainable. Improving the infrastructure and being more inclusive of traditional healers. And lastly, and the most importantly, is that we start having exchange programs along with regional collaboration that is being done through Spice Road, but it would make more differences if we turn into a rural exchanges where we can, learn from the neighboring countries and then incorporate our successes here and bringing in their successes to our country. So I think all in all, we talk about Pakistan, India, Bangladesh. There have been a lot of activities which are run on the NGO levels, but the government needs to take a bit of initiative. And along with that, I think the younger doctors and the young folks need to have a collaboration, not only in academic, but also to enhance the clinical skills. Thank you so much. And once again, thank you for having me.
Thank you, Dr. Anam, for giving an overview of how family medicine and primary care is practiced in Pakistan. So before we wind up, I would like to pose one question to Dr. Sangha. So how can you feel the young doctors and family physicians collaborate globally to strengthen primary care practices and address the common challenges?
Vishnu, can you repeat it? I didn't hear the last. Vishnu?
Dr. Sangha,
No,
Can young
you're,
family
go ahead.
physicians collaborate globally to strengthen family care practices and address the common challenges of the current scenario?
Yeah, thanks for that question. I think the most important thing is networking. What I have learned from the beginning of my career, especially my career in Bonga, what I have realized is the importance of networking and importance of talking to each other and sharing experience. Because you will never come across any problem that has never been come across by another person. There are no new questions. There are no new problems. These problems are more or less have been experienced by other countries, other people, other practitioners. So having a good network, talking to each other, sharing experience is very important. I think that is the most important thing to go forward and to improve ourselves, not only ourselves, our systems, because we always contribute to our systems. And for this, I hope now it's very importantly we have virtual platform. So before this, it was only we have to physically attend the conferences or physically we have to interact with people. But more or less, I mean, fortunately or unfortunately, due to COVID and after COVID, we have more virtual platforms and we have more ways to interact with each other. So I think we have to make use of that. We have many platforms. When you take Wonka, we have a lot of ways to communicate with each other, to collaborate with each other. Use them. Use all opportunities, but always use them consciously, wisely, and share your experience with each other. And this is the pathway for to learn from each other and to improve our systems. And I also want to add something, because when you take or talk about changing systems, one important thing is you have to you have to involve in policy making. So you have to be advocates of your government, your local systems, your local bodies, your local councils, and the places where policies are made. So we always know that most of the family doctors are not much interested in policy making or policy advocacy, but this is very important factor, because most of the public health specialists are involved in this. So most of the time, primary healthcare is represented by primary preventive care, and the primary curative care or the primary care is ignored where the family medicine is. So I always encourage you to learn and involve in policy making, advocacy in every level, from the micro level to macro level, and also to get involved with the global community of our family doctors, family of our family physicians, to collaborate and to go forward to improve ourselves as well as our systems. Thank you.
Thank you, Dr. Santa, for sharing your experience and thoughts and also addressing the concern on how to move forward. Now, one question I would like to pose to Dr. Hanna. Could you highlight the innovations or programs in Pakistan's primary care system that have made a significant impact on community health, which you feel other countries should replicate?
Thank you, Vishnu. I think the only one thing that our ancestors gave us was a strong academia. So that is one thing that you need to have structured training and you need to have more innovation towards it. I'm sure, Dr. Sankar said, that the untrained, but because, committing for 4 years program is very, it's not doable for a lot of people. So probably coming up with a much, flexible training programs where people can come in, have their knowledge updated. So building up academia is one. And second, that I am very proud of the people from our North Pakistan, KPK and Upper Punjab. What they have done is that they've really gone to the root cause and started collaborating and being inclusive of the regional traditional healers and integrative medicine. So they've started evolving it into their their practices. So that has given a lot of it has actually opened doors to a better healthcare facility to the people who were deprived of it for all these years. So that is one thing that I really believe had changed things in Pakistan, which is to get in touch with the rural population and know what their problems are, and then providing the care according to their expectations. So that has been very different. I'm sure the other countries are doing the same. It's just that our issue was that for till very long time, till 2018, we were just building onto the urban side of and tertiary care institutions were taking the lead. Now the government and the general practitioners have been much more advocate in this. So I think that has changed a lot, and that is a issue in our region and needs to have a very strategic planning, and we should be very stringent about it, because if we don't work on it right now, probably in the coming years we would not be able to engage them in a better way.
Thank you, Dr. Anam, for sharing your thoughts. I would like to thank Dr. Sankha and Dr. Anam, and also special thanks to Dr. Kinli Bhuti, who is the chair of Spice Group South Asia region. And thank you for sparing your time and joining our session.
Thank you, Vishnu. Thank you, the Spice Route, as well as the AFPI Kerala Chapter for inviting us for this session. And we can engage more. We missed the live audience. Anam would agree with me. We can't see anyone there, unfortunately. Soon we would like to see you.
Thank you so much, and all the very best for the upcoming conference. We are very excited as a Spice Route region, and we really look forward to the things you people are doing. And congratulations on putting up such a conference on. And thank you so much for inviting us.
Now I invite Dr. Aishravi Nambudiri. She is the specialist family physician at KIMSL Trivandrum and the chair of Spice Route Kerala, to address the gathering on the family medicine practices in India over years.
Hello everyone. I would like to talk about the history of family medicine in India. So, family medicine in India has evolved over the last decades into a well-recognized medical specialty. The Medical Council of India Act 1956 was amended in 1983 to recognize family medicine as a medical specialty. The National Board of Examinations, NBE, has promoted family medicine since 2005. The first postgraduate course in family medicine in India was launched in 2011 at the Government Medical College, Calicut, Kerala. So the early adopters and innovators took the lead in implementing training programs in family medicine. Dr. Prakash Chand Bhatla is the father of family medicine in India. He founded the IMA CGP, and his foundational work led to the recognition of family medicine specialty in India. Due to his efforts, family medicine was included in the list of recognized specialties by the National Board of Examination. He is also one of the founding forefathers of WONCA, the World Organization of Family Medicine Doctors. So, coming to the recent developments of family medicine in India, as already mentioned, Calicut Medical College was the first institute to start MD family medicine program in India. Earlier, only DNB courses were there. Under PMSSY, all recently established AIMS-like institutions have started the Department of Community and Family Medicine, which is a welcome change. The MCI has been replaced by the NMC with the aim of promoting the discipline of family medicine. So this was what I was just mentioning. Now coming to the total number of PG seats, there are around 52 DNB institutes with 151 DNB family medicine seats, around 109 institutes with 317 diploma in family medicine seats, around 10 institutes with 21 seats in MD family medicine. Coming to the family medicine PG seats in Kerala, there is MD family medicine course in Government Medical College, Calicut, and DNB family medicine courses are there in around 10 prominent hospitals in Kerala like Lutz, Kims Health Trivandrum, Medical Trust Hospital Kochi, VPS Lakeshore Kochi, Muthoot, Koranjeri and Pathanamthitta, Aster MIMS Calicut, Apollo Atlas Angamali, and ICRA Hospital Calicut. The Diploma Family Medicine course by NBEMS is present in Ahalya Hospital Palakkad and Medical Trust Hospital Kochi. MD Family Medicine course is available in many prominent medical colleges in India, like CMC Vellore, Calicut, St. John's Medical College, then in various AIMS. And MD Family and Community Medicine seats are present in a variety of places in AIMS, like Bhopal, Patna, Rishikesh, etc., and also in PGI Chandigarh. Now coming to AFPI. What is AFPI? AFPI is Academy of Family Physicians of India. It is a national organization committed to promoting and strengthening the practice of family medicine in India. It was formed in 2010 and it was first registered as a charitable society in Delhi. Founder president was Dr. Raman Kumar, who also played and still plays a very important role in promotion of family medicine. AFPI plays a vital role in shaping the healthcare policies, promoting education and supporting family physicians in their critical role as healthcare providers. It provides CME opportunities, conferences, and practical as well as exam-oriented workshops that allow family physicians to stay updated on latest advancements in healthcare practices. AFPI Kerala, the official formation of AFPI Kerala with the installation of the first state executive board was in October 2014. The founder president is Dr. Bijay Raj, and the idea was taken forward by Dr. Bijay Raj, Dr. Sirin Kuriakos, and Dr. Jitesh. There are many prominent leaders in AFPI Kerala like Dr. Reshmi S. Kamal, Dr. Indu Rajiv, Dr. Tanya Pillai, Dr. Zarin, Dr. Anand, Dr. Shahzad, Dr. Anup KJ, Dr. Kailas, Dr. Jisha, Dr. Abdul Rasik, Dr. Mansoor, and Dr. Nadeem. So there are various milestones that AFPI Kerala can boast about. It is the first state to conduct state conference in January 2015 at Calicut. It was the first state to conduct national conference outside Delhi, that is FMPC 2017. It is the only state to have conducted 8 state conferences so far, this being the 9th. The best state chapter award was given by AFPI at FMPC 2019. Operational guidelines was prepared in 2020. There are also 3 zonal chapters, North, Mid and South zones, with zonal EBs formed in 2017. District branches with district coordinators were formed in 2017. There is a media wing called AFPI Kerala. Samagra Argyam is official video partner in FB and YouTube. We also have quarterly newsletter issues and Academic and Research Committee, ARC. Now coming to the Spice Route India movement. It was officially inaugurated in 2010 at Kathmandu, South Asia Regional Conference. The objectives of Spice Route India movement include to improve education and training of young family medicine doctors, that is those in family medicine training and in the first 5 years of family medicine practice. To increase opportunities to develop skills in research, publication, presentation at national, international fora and also exchanges. To give platform for young family doctors to express their doubts, concerns and aspirations and to help in addressing them, and also to encourage leadership among the young family medicine doctors. Activities include continuous professional development programs, pre-conferences, workshops, symposia in national and international fora, research, social media activities, exchange programs and fellowships. Leaders, Dr. Gunjan Jha, she is the National Chair, Dr. Bidyut Banerjee, National Secretary, Dr. Vishnu B.S., National FM 360 and PG Coordinator, Dr. Anuna Vinod, she is National Image Editor, Dr. Vajjaswati, National Treasurer, Dr. Serin Kuyakos and Dr. Jyotika Gupta are the advisors. As we all know, family medicine practitioners have various roles and responsibilities like managing common medical and urgent care needs in daily practice, providing domiciliary and palliative care with appropriate referral to specialists, effectively manage common diseases in all age groups, provide community-oriented care with multidisciplinary approach, and health promotion and primary prevention. So, of course, there are a lot of challenges that we face. The way forward includes establishment of departments of family medicine in medical colleges all over India, and necessary steps should be taken to incorporate the family medicine curriculum into the undergraduate MBBS curriculum. The number of medical colleges offering postgraduate residency training in family medicine should be increased. Development of a comprehensive curriculum to meet current healthcare needs of the community is required, and increase the number of rural family medicine doctors is the need of the hour. We should also spread awareness among the public and health stakeholders. So that's all. Thank you.
So with that, we come to the end of the Space Route session, and we'll break for lunch and join post-lunch at 2 p.m.